chairpersons, past presidents, members of the council, members of the college, all the PG trainees, ladies and gentlemen. It's a great honor and privilege me to stand before you today in the second day of academic sessions. As you know, our theme is managing healthcare with leadership wisdom through academic excellence, managerial excellence, and emotional intelligence. Today we focus on academic excellence pillar. That is why we requested Professor Sumati Pal to speak on qualitative insights for strategic healthcare leadership. Professor Sumati Pal is a professor of psychiatry at King's University, UK, and honorary director of the Institute of Research and Development, Sri Lanka. Professor, we are very grateful to you for joining us and sharing your deep insights into qualitative thinking and strategic decision-making in the health sector. I welcome you. Dr. Neelamani Hevagana, past presidents, I welcome you, madam. You are one of the co-chairs of this session, the innovative session. So we are first plenary, Professor Sumati Pala will talk on this subject area, how to be excellent in research. Then there will be 12 innovation presentations that will be judged by 3 judges. So I thank all the judges as well as the chairpersons for being here with us today. So we had a very productive sessions yesterday as well. More than 80 were participated here. And today also I hope that we can have a very interactive session. I must thank all the participants for your engagement and request you to have a very interactive session today. With that note, I conclude my opening remarks. Over to Darshan to continue the proceedings. Thank you.
Thank you, sir. Without further delay, let's step into the first component of the session, titled as Beyond the Numbers, Harnessing Qualitative Insights for Strategic Health Leadership. The session will be co-chaired by Dr. Neelamani Hevagigana, Madam, and past President of the College, and Dr. Sudha Dharmaratna, President of the College. I kindly request the co-chairs to take their seats. Let me have the pleasure of introducing the co-chairs. Dr. Neelamani S. Rajapaksa Hevagigana is a distinguished medical administrator and a board-certified consultant in medical administration, whose career exemplifies unwavering commitment to strengthening Sri Lanka's health system. She holds a Doctor of Medicine from Postgraduate Institute of Medicine, University of Colombo, and a Doctor of Philosophy from Sheffield Hallam University, United Kingdom. Dr. Hevagigana has served the Ministry of Health in several high-impact leadership roles, including Deputy Director General Planning, Director of Health Education Bureau, Provincial Director of Health Services, Uva Province, and Regional Director of Health Services, Badulla. Through these positions, she has contributed to policy development, system reforms, capacity building, and health promotion at national and provincial levels. Her academic research contributions are equally noteworthy, with 25 publications in national and international journals. She has advised the scientific discourse in health systems, administration, and public health. Her excellence has been recognized through seven major awards, including the Best Academic Performance Award, MD Medical Administration in 2006, 2 National Research Council Merit Awards, and SLMA CNAPT Best Publication Award in 2014, and the prestigious SLMA Sir Nicholas Artigaler Prize 2012. Dr. Hevagigana is also represented a respected academic mentor who has successfully supervised 6 MD trainees, 16 MSc candidates, 9 MBA graduates, and several undergraduate students. Her international consultancies include assignments with the Asian Development Bank's Health System Enhancement Project, the Royal Government of Bhutan, and the WHO CRO office, reflecting the global standing. As past president of and a fellow of the College of Medical Administrators and former council member of the Sri Lanka Medical Association, Dr. Hewagigana continues to serve the profession with distinction. Presently, she is the editor of the Independent Medical Practitioners Association and an editorial member of this College of Medical Administrators of Sri Lanka, president of the advisory board of All Ceylon Buddhist Student Federation, and a director of Sati Pasal Foundation. Dr. Sudha Dharmaratna is a distinguished medical professional with extensive experience in healthcare administration, medical education, and clinical governance, currently serving as a senior lecturer at the Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. He earned his MBBS from the University of Colombo and his MD and MSc in Medical Administration from the Postgraduate Institute of Medicine, University of Colombo. He completed his overseas training at King's Mill Hospital, Sherwood Forest Hospital Foundation Trust, NHS, United Kingdom, in 2010. He began his career as a medical officer in pathology and rose through the ranks to become the Deputy Director General of Laboratory Services, retiring in 2024 after 32 years of service. He has held key posts, including Director, District General Hospital, Gampaha, Regional Director of Health Services, Gampaha District. Dr. Dharmaratna's leadership at District General Hospital, Gampaha, pioneering quality improvement program, earned him several national awards for his excellence. During his illustrious career, he served as the Director of National Hospital for Respiratory Diseases, Valisara, Director of Disoisa Hospital for Women, Director Tertiary Care Services of Ministry of Health, and Director of Healthcare Quality and Safety. Dr. Sudha Dharmaratna has made significant contributions to controlling the emergence and spread of antimicrobial resistance initiatives and has been instrumental in strengthening COVID-19 RT-PCR testing laboratories in both the public and private sectors in the country. He was instrumental in establishing genomic sequencing facilities in the Medical Research Institute 2022. As an academic, he has served as a member, the Secretary of the Board of Study in Medical Administration, and the Chief Examiner, and continues to serve as a senior lecturer at PGIM, shaping the next generation of medical administrators. He has numerous research publications in healthcare quality, hospital management, and medical equipment management. His contributions continue to strengthen healthcare governance and leadership, as well as postgraduate training of healthcare professionals, including medical administrators in Sri Lanka. Beyond his professional achievements, he is remembered for his excellence in sports as an athlete and a captain of rugby team at the Faculty of Medicine, University of Colombo. Dear Madam and Sir, over to you to proceed with the session. Thank you.
Thank you very much, Ashana, for that. Good morning, everybody. Firstly, let me humbly request for you all to put all your phones in the silent mode. It is my privilege to welcome you to this plenary session where we move beyond the numbers to explore how qualitative insights can deepen our understanding, sharpen our decisions, and strengthen strategic leadership in healthcare. Let me invite my co-chair, our president of the college, to read the citation of our speaker, Professor Atula Subutipala.
It is a distinct honor to welcome Professor Sumatipala, a globally renowned figure in psychiatry, global mental health, doing research and bioethics, to deliver this plenary lecture. Professor Sumatipala's distinguished career spans both Sri Lanka and the United Kingdom, embodying a unique commitment to addressing the global health research divide and ensuring ethical research practices in low and middle income countries. Professor Sumatipala currently holds significant appointments, including Director of the Institute of Research and Development in Health and Social Care, Sri Lanka, Emeritus Professor of Psychiatry at King's University, United Kingdom, and Emeritus Professor of Global Mental Health at King's College, London, and Visiting Professor in Psychiatry and Biomedical Research at the Faculty of Medicine in Kothalaula Defence University, Sri Lanka. His dedication to academia and research excellence is further highlighted by his roles as the current Secretary General and the President-elect for 2026 to 2028 of the International Society for Twin Studies and as a key editorial board member for prestigious publications like British Journal of Psychiatry and the Ceylon Medical Journal. He was recently appointed as the chair of the Committee of Ethics, Governance and Research Integrity at the Ministry of Science and Technology. A graduate of Faculty of Medicine, University of Colombo, Professor Sumatipala holds multiple advanced degrees, including an MD in Family Medicine and PhD from the University of London. He trained in psychiatry at the prestigious Bethlehem Royal and Maudsley Hospital in London, acquiring his CCST, MRCP Psychiatry, and FRC Psychology. He is an honorary fellow of College of the General Practitioners and College of Family Physicians. He is the only Sri Lankan to receive H.P. William Travelling Professorship for Royal Australian and New Zealand College of Psychiatrists. His varying research has earned him international recognition, particularly in the fields of twin research. He is the founder of the Sri Lankan Twin Registry, a unique and large-scale population-based resource for twin and genetic research in South Asia, and a key achievement that received a national award for outstanding leadership in science and technology in Sri Lanka. Medically unexplained symptoms, MUS, Professor Sumatipala has developed and tested culturally sensitive interventions, including cognitive behavioral therapy, based model rooted in Buddhist philosophy. Now is being mental health epidemiology, migration and displacement, disasters, and bioethics. His work frequently focuses on epidemiology of chronic disease, comorbid mental and physical illness, and crucial ethical frameworks necessary to protect vulnerable research participants in global health settings. Professor Somatipala's research has attracted numerous competitive grants from major international bodies, including the Wellcome Trust and Medical Research Council UK. He has authored hundreds of publications and advises the World Health Organization. His life's work is a testament to the power of sustained, ethical, and locally driven research to influence global policy and practice. This plenary lecture will eagerly anticipated by us as an opportunity to gain insights from one of the leading global health researchers over time. I cordially invite you, sir, to address the gathering. Thank you.
Good morning, everybody. Dr. Sudha Dharmaratna, thank you for that kind introduction. Dr. Nilamani Hevat Giganage, the co-chairs. I consider it as an honor to be here with you all today. I'm very mindful that we are facing a major disaster in the country, so you may have to take your calls. I have to apologize. I get easily distracted from when people, use the phone when I'm talking. So I'll plead you, if you have to answer the phone call, please go and come back. Apologies for saying that because I don't want to be distracted. So your 32nd annual scientific sessions Your theme is managing healthcare with leadership wisdom through academic excellence, managerial excellence, and emotional intelligence. I have been asked to talk about beyond the numbers, harnessing qualitative insight for strategic health leadership. So I have decided to dissect this title into beyond numbers, harnessing qualitative insights, strategic health leadership. I've taken also from your theme, emotional intelligence and academic excellence. And I thought I'll give a narrative of our research strategy we have come to as a case study. So I'm not going to read a script. I'm going to tell you a story. It's a narrative, part of qualitative research. Theory and practice will unite together at the end of the lecture for learning, and I'm going to cite a case study. Why beyond numbers? You know, quantitative indicators tell us what is happening, but rarely tell us why. For example, clinic attendance. You may get the numbers, but you may not understand why people bypass peripheral hospitals and come to centers of excellence. Why qualitative evidence matter for leadership? Limits of numbers alone, what surveys and indicators miss meaning and content, and at times power relation and lived experience. Qualitative findings change priority, uncover unintended consequences, and reveal feasibility issues. Leadership, which is very crucial, leadership decisions depend on narrative insights rather than numbers. So harnessing qualitative insights refers to process of utilizing non-numerical data to gain deep understanding of human experience, behavior, and motivation. This involves methods such as interviews, focus groups, and observations, which allow researchers to explore the underlying reasons behind actions and decisions. Qualitative insights are crucial as they provide context and depth, enabling organizations to make informed decisions based on real human perspective. By analyzing qualitative data, researchers can uncover patterns, themes, and meanings that quantitative data may not reveal, ultimately leading to more actionable insights and effective strategies in various fields, social research. I apologize for this typo. Okay, so I actually had to redo my slides because of the disaster. So this is numbers. Tell us something, but not everything. But this picture tell us something more. These pictures tell us more in depth. So that's called photo voice. Photo voice is a participatory visual quality research method that combine photography and narrative storytelling to capture individual lived experience. So qualitative versus quantitative, as we know, qualitative study in depth, whereas quantitative is breadth. So when it comes to qualitative research, I have noted here, I'm going to share my slides with you all. So certain things I may not go very deep into considering the time. So qualitative research is different. It's not concerned about numbers. And there's this overlapping area, which we call mixed method. So from story to strategy, making qualitative insight actionable, the leadership process, the strategy would be capturing opportunity. I strongly believe capturing opportunity should be the strategy, and we are facing a major disaster. We should capture as an opportunity to do things differently. Qualitative research, themes identified, priorities decided, and actions taken. converting raw narratives into actionable leadership decisions, translating themes into decision-ready outputs, policy brief, prioritization framework when a theme requires immediate operation, change, or longer-term policy shift, creating usable qualitative recommendations. I was initially going to make this project program as my case study, but considering the disaster situation, I thought I'll bring in some of our experiences, which we gained post tsunami and also COVID-19, to make the theory and practice into one case study and tell you how to learn from our negative experience. So there are leadership styles: autocratic leaders make decisions unilaterally. Democratic leaders involve team members in decision making. The next one, leaders give employees freedom in their work. Transformational leaders inspire and motivate team members. And transactional leaders rewards and punishes based on performance. So there are overlaps. It's not mutually exclusive. And there are pros and cons in each and every category. One size does not fit all. So Kurt Levin's leadership style, the autocratic leaders, democratic leaderships, laissez-faire leaderships. And the issue with this model is that there are pros and cons. No mismanagement, pros, self-motivation, creative freedom and growth. But the cons are accountability issues, lack of direction, and inefficiency. So there are pros and cons you need to think. Again, when it comes to leadership styles, you can see from this one, there are transformational, democratic, laissez-faire, autocratic, as well as supporting, coaching, delegating, directing. I'm not going to go into details about it because I'll talk through it later. And there are activated leaderships, dictators, mobilizers, and there are dormant leaderships as well. But the message here is the leadership's benefit of adapting your leadership style. As I told you, there's no one size fits all. Now, from get people out of a sinking ship, you can't have democratic discussions because the ship will sink. So you have to adapt your leadership style to suit the situation. From a sinking ship, you have to act like a dictator, get the people out of it, but later you can sit down and discuss what went wrong. Now, what type of a leader are you? It's very important to pause and reflect. Sometimes people act and act and act, don't reflect. The transformational leaders, there are key characteristics, strengths, and challenges as well. The transactional leaders, same. The situational leaders, there are pros and cons, strengths, weaknesses, limitations. The servant leaders are also same. It's crucial you discover yourself through reflection. At times you have to stop, pause, and reflect. Now in leaderships, there are visionaries. There are very clear visionaries who foresee things very far. There are theoreticians who will split hairs. There are activists who sometimes may be like a bull in a shop. And there are pragmatists. So exceptional leaderships would have all these qualities, but such leaders are rare. So you have to have a team who has vision. There are theoreticians, there are pragmatists, very important. And there are activists who deliver. So if you give the activist the leadership role to do vision, it's not going to work. So you have to identify your team members very clearly and learn their skill set and delegate them with the task they can deliver better. Otherwise, you fail. So as a leader, you need to identify your team members and their strengths, weaknesses, limitations. But there are people who may have all this, who can switch from one to the other, become a visionary, then become an activist, become a pragmatist or theoretician. There's a difference between a boss and a leader. The boss's demand relies on authority, issues ultimatums, say, I use people, take credit, place blame on the others when things go wrong. But the leaders are coach, relieve in goodwill, relies on goodwill, generate enthusiasm, always say we, develop people, give credit, and take the blame if something goes wrong. Says, let's go. Strength is the unity in such a leadership. So exceptional is different from good, great, or excellent. There should be exceptional research, exceptional researchers, but more than that, we need exceptional research and academic leaders, which is theme of your Congress. So excellence go beyond building and managing research teams, effective supervision of postgraduate research. Excellence go beyond building your own expertise, securing grants, and marking outputs. It's about strategic vision, remember that, and strategic alignment of research for impact. That impact should be for the nation's benefit. Exceptional leaders are inspiring, they are motivating, and they are engaging. The visionary have a vision for success, both short-term and long-term objectives. Relatable, build relationship with those around them by identifying shared values and common interests. They are influential. They know how to use influence wisely. Influencing others take more than simply having power. Assertive power can assert power appropriately without being overbearing or authoritative. And agile, ready and willing to adapt when change occurs in their environment. If somebody can't change based on the demand, that's a huge weakness. And that's very important to remember. So therefore, exceptional leaderships have more than technical skills. Remember, one can be an expert on theory, everything, but leadership skills, you need certain things beyond theoretical skills. You need to have conceptual skills more than that interpersonal. How to work with other people, how to learn from other people. And leaders should always be in a position to take a back seat. We all are leaders at one point, but at one point, we are followers. So if a leader can't take a step backward and be a follower, that's a great thing. You can't be leaders every time. And sometimes your team members may come up with things. They may know things more than you. So you have to be very flexible, humble to accommodate such team members' suggestions. Now see this. Hope it works. See what a chaos in this team. Still nothing is happening. Tires are changed. Still they can't take it off. It's a classic example of bad leadership, bad team. Okay, finally. But look at this one. They are ready even before the vehicle arrives. tires are changed with no time, the vehicle take off. Prepared in advance. That's a strategy, teamwork, effective leadership. That's one. And this is one of the most favorite things which has inspired all of my life. A man who was sweeping NASA corridor was approached by a media man and asked him what is he doing. I'm working to put a man on the moon. He didn't say, I'm sweeping. If it was in Sri Lanka, somebody might say, I'm sweeping the corridor. But what does it tell you? That he was in a team with a great leadership who made him comfortable to think he is a proud member of that team. Everyone matters, remember that. In your team, everyone matters. Like a machine, if one bolt goes off, the whole machine will collapse. So this is where the emotional intelligence comes in to kick in. Positive attitudes and for leadership. Daniel Goldman was the man behind this. Emotional intelligence, the intelligence quotient is different from emotional quotient. It's related to limbic system of the brain. You may be born, there's a genetic component to it, but most of it could be acquired through skills. This is an absolute must for leadership. If you don't have emotional intelligence, cultivate it, grow it, learn it, otherwise you wouldn't be a good leader. Emotional intelligence makes you self-aware. It regulates yourself. There's control. There is motivation. There is empathy. And most of it, interpersonal skills. You can bring in your reflective abilities, self-regulation, motivation, and you relate to your team members. You communicate well. That's important. So communication is crucial. You can't say, do it. Let's do it. The voice, the tone, walking your talk is essential. And you have to be patient. At times, things may go wrong. You may not be able to do it at once. And you should have a very good pair of ears, listening skills, relationship, trust, compassion. All of these are part of emotional. Self-awareness, what is it? The ability to recognize and understand your own mood, emotions and drives when you feel angry. Human nature is such, all of us feel angry. Getting angry is fine. That's normal. That's natural. But remember, verbalizing it is the most important thing. You should be able to say it in a way the other person can listen to and absorb it. Otherwise, people put fingers on their ears. Understanding their effect on others. When you get angry, when you put off people, when you criticize destructively, your team members wouldn't respect you. Your team members wouldn't act with respect. So, such leaders have self-confidence, relying on self-assessment, and also have sense of humor as well. Self-regulation, the ability to control or redirect your disruptive impulses and moods. Remember, anger is an energy. That energy can be channeled positive to make a difference. Being not judgmental, thinking before acting, acting but not reacting. Characteristic, trustworthiness and integrity is an absolute must. You can't live within a glass house and demand other people to do right thing. Integrity, you cannot compromise if you are a good leader. You have to be comfortable with ambiguity. And you should also be humble to change when that change demands you to change. And motivation. It's a passion, remember that. You work not for monetary benefit. We all need money to live. But money is not everything, remember that. Energy and persistence. At times you'll be very stressed up. And characteristics are strong drive to achieve. But not achieving something for your personal benefit. You have to be optimistic. I always say malignantly optimistic. And organizational commitment is an absolute must. Empathy, the ability to understand the emotions of others, fitting to other person's shoe. Skills in treating people according to their emotions. If you recognize a face with no mood, disappointed, demoralized, that's okay. Things go wrong. Let's get together, do it. Encouragement. Putting yourself in their shoe, understanding and characteristics are expertise in building and retaining talent and cross-cultural sensitivity. Social skills, ability to manage relationships and build networks, ability to find common grounds and rapport, and characteristics of such leaders are effectiveness in leading change. Persuade. You should be able to persuade other people. Developing in emotional intelligence. That's an individual approach. You feel you don't have that, you can be taught, coached, you can learn it. You can coach other people, you can mentor people to do so. Feedback loops are very important. Feedback should always be non-threatening, non-judgmental, non-destructive. And it's a commitment, and it also can grow through experience. What are attitudes? Attitudes are the way you think or feel about something. It's a psychological construct. It governs your behavior, though. Cognitions are assumptions, beliefs, thought, structure, psychological construct. And remember, cognitions, the way you think determines how you feel and how you behave. By changing the way you think, you can change the way you feel and way you behave. Lord Buddha, when Kisa Gautami approached and asked to give life back to her son, Lord Buddha said, go and bring some mustard seed from a house where nobody was dead. He didn't say anything else. Kisa Gautami went from house to house, house to house, house to house. Lord Buddha used the behavior. And Kisa Gautami realized that there's no house where nobody died. She changed the way she thought about death and emotion. Yeah. That's my bread and butter research, cognitive behavior therapy. So I always tell my Western colleagues that this is our tonic in your new bottle. Even Aaron Beck says that. So that's why, it's very important to think and reflect how you feel, how you think, and why you behave. And it's very easy to change. And sometimes people become learned helpless. Seligman did a lot of research on this. And the other bad thing is conformity. There are a lot of research you can read up. I'm not going to go into detail. Milgram did a lot of studies. He drew 9 lines. The 9th one was very clearly short. He sit 9 people in a table. 8 of these people are stooges. Only the last one came from outside. So he asked from everybody, are these lines same or not? All the stooges say same. 80% of people who come from outside say same. So he challenges and says, no, this is clearly short. Why do you say so? So they say, how can I say when the great majority says same? So that's conforming. You have to understand, pick up, and learn not to conform to wrong things. So remember, a bad attitude is like a flat tire. You can't go anywhere without changing that tire. and attitude change everything. Remember that. Negative attitudes has to be challenged, changed, and things done separately. Good leaders can change internally and can make things change externally. So very important. All this boils down to ethics, power, and reflectivity in qualitative research. There are power dynamics, remember, between researchers, managers, your bosses. I'm pretty sure you have come across. There are egoistic people, arrogant and ignorant. They want things their way. You have to challenge them. But challenge the positive. Reflexivity is a leadership skill. How leaders integrate their own assumptions when using qualitative evidence. So this brings me to a very important third eye awakening message for you all. Reflections are needed right now within our systems, individuals. Local evidence-based decision making is a must. Barriers and facilitators to translating research into policy and practice for national benefits is a must. There are individual characteristics and systems or organized factors in there which you need to take into consideration. Systematic scientific evidence and public policy systems review barriers and enablers to evidence-based decision making. Remember, breaking barriers to facilitate translating research into policy and practice is a must. Why? Local evidence-based decision making is a must. 25 years ago, we did a survey of 5 leading journals for 5 years in psychiatry to find only 6% of research come from 90% of the world. We repeated it 20 years later. It has only gone up to 12%. So we thought maybe this is psychiatry. We went and analyzed leading medical journals, which you all read. New England Journal, JAMA, Lancet, to find the same fate. Only 6.5% comes from 90% of the world. We repeated that later. It has gone up to 12% only. So, is it evidence-based medicine or evidence-biased medicine? You're not practicing evidence-based medicine. This is somebody else's evidence. Whose evidence is it anyway? So, if we are critical of existing evidence, the solution is local evidence-based approach. So that's why as administrators, you should be encouraging other people to have your own evidence base. I'm sorry, I'm getting distracted very much. Please, please. Because I don't want to break the flow of this train of thoughts. So there are systematic scientific evidence of public policy system review. There are barriers and enablers. Remember, at times, individuals in authority are barriers for progress. Please don't be one of them. Don't have too egoistic things. Be humble. We live on taxpayers' money. We are educated from taxpayers' money. We have to leave our ego aside and do something good. So this systematic review very clearly shows finding highlights the urgent need to institutionalize scientific evidence in policy formulations through formal governance framework, sustained stakeholder engagement, and robust science policy intervention. Advancing transparent, inclusive, and evidence-based governance will require cross-sectoral collaboration at this moment in this disaster. Cross-sectional collaboration, and political leadership committed to bridging the gap between research and policy. Now, the Ministry of Science and Technology has established a committee, ethics, governance, and research integrity. It was one of our colleagues, Sushant Abesen, who's a public health professional, who came through his and our work at the Institute for Research and Development for 25 years. Sri Lanka Medical Association, ethics, Kandani Wanikatunga, then Janaka Pushpakumara, and NRC, National Science Foundation. So I was appointed as the chairman in this committee to lead, and there are 15 members. Only 5 are medics, the other ones are non-medics, because we are talking about non-medical research as well. Human research, animal experiments, non-human, non-animal, big data, artificial intelligence, social sciences, and other types of research. Multidisciplinary, multi-sectoral. To facilitate, not to hinder research. Sometimes people do perceive ethics as a barrier. Why? Because ethics is a critical but supportive friend of research. That is why research should be viewed through an ethical lens, and ethics and governance are essential prerequisites of research. Okay, this was mostly theory. I'm to bring you some solid evidence how we have walked our talk, bringing theory in practice. And research ecosystem in Sri Lanka, there are strengths and weaknesses. Strengths, we have over 60 research institutions. Private industry, there are top 2% world ranking researchers in our country. We have a Ministry of Science and Technology. We have international collaborations, international grants coming in, media supporting, IP office, Invention Commission. But the weaknesses are boundary line, marking your own territory, don't cross it. This is my line, my territory, like dogs. No multidisciplinary approach. Traditional medicine research doesn't have a place. It's a sprint, 100 meters for publication, decrease, and career boost. And it's all around. There's no harm in getting all these benefits for you, but it has to be beyond yourself. That's the weakness we have. The stakeholders, the Ministry of Health, sometimes these directorates, they act. I'm critical. I don't hesitate to criticize when I have to. They don't work together. Don't cross my boundaries. This is what we want. No, family health is family health across the board. Don't remember there are other stakeholders as well. There are provincial health directors and curative services, different institutions. Most importantly, people. They have a voice. They should have a voice. They have lived experience. They are experts by experience. We are experts by learning. So the other weakness, we don't have adequate amount of funding. We are even below Nepal. But remember, money is not everything. We need a overarching research culture. We need a relay, long marathon, research impact beyond academic impact for product and service development. What for people's benefit. Implementation research is therefore very important. That's what I'm coming. Removing snacks of bureaucracy, breaking bottlenecks, particularly physical and psychological barriers to progress. We need a strong push. We need a culture shift. We need trade unions to think beyond petty ownerships, demand, education system. The public should be part of it. And the political leadership has a huge role to play in this, bridging these gaps. Okay, the missing link is knowledge exchange, dissemination of research findings, how to share with lay people, writing a lay summary, using media, and co-creation and co-production, getting your most important ally, the resource participants, part and parcel of your thing. So implementation science is important. Engaging the community is important. Fully integrated mixed method research is important. Multidisciplinary approach is important. And multi-sector approach is also important. Participatory approaches, that's what the about, qualitative method, taking into consideration the voice of community, action research, all these are very important. And remember, community engagement and involvement can be throughout the research cycle, right from the beginning, even making a research question, developing it. We convened 40 experts from Australia and England, the region in 2018 to draft the protocol on child development autism project. We brought in 5 mothers who care for autistic children. They said, this is excellent, this is good enough, but that's not our priority. We changed the whole workshop and we developed the proposal according to what they needed. So remember, they are educated, they not be having degrees, but they are experts by living. So you can, right from the beginning, in designing the question, throughout the research cycle, use them. We do that. So our resolve is to bring all these, partner them to make a difference, maximizing the strength and minimizing the weaknesses. I'm going to skip through some of these because I'm mindful of the time. So at the Institute for Research and Development, which we work for 25 years, we have 3 pillars: research, ethics, and community involvement and engagement. And the roof is capacity building for international collaboration. But this is our brand. This is what we sell to the other people. That's what I'm trying to do, increase the visibility and plead with you. And it is published, Key to Success, Global Health Collaboration, Research, Ethics, and Community Involvement and Engagement. So now, last part of my talk. I told you at the beginning, theory and practice, bringing together learning. I'm going to share a case study. Originally, I was going to talk about only one, but I'm going to rush through a little bit because of the context right now. During tsunami, there was the first wave of real tsunami, and there was second wave of man-made tsunami. A lot of AIDS came in, cultural intrusion, compulsory counseling, multiple needs assessment. We left no stone unturned to make a difference for our nation. Because disaster, this is what something I coined, disaster, D is destruction, death, disease, displacement, disappearance, disorder. It has psychological and ethical impacts. You can reflect right now, all this is happening. People are suffering. There are psychological issues and there are inherent ethical issues in all these. So we did a situational analysis. We had a team. We went to down south straight away. We didn't plan from Colombo. You can see this. When we were coming back, we saw these people cleaning, even the foreigners cleaning wall. So the immediate message, photo voice, was our nation is a resilient nation. I vouch we will bounce back even from this. But we have to learn a lesson from Argentina. Come to that. It's a political message. Then there was a lot of AIDS coming in. The Western countries were dumping their junk. We had to spend millions of rupees to. Based on all this, we did this proposal to Center for National Operation under the president at that time. Current Prime Minister was working with me at that time in this committee. So we brought up few things. Children first, not to forget them, because children are forgotten, even this one. So we went and gave play material, drawing material to kids. Some people took away play material and played. That's how they cope. Some people went and started drawing. You would notice from this, the theme is, this is again the power of qualitative research. Different camps. The message was clear. Became a huge campaign. The newspapers taking it, and it went so much people start giving drawing material and saying, draw tsunami. I had to intervene and said, don't ask them to draw tsunami, let them draw what they want. After 3 months, they stopped drawing tsunami. We did island-wide mental health survey, school survey, dropouts and all that. And this campaign went so big when Bill Clinton and George Bush came, the memorabilia they got were drawings, children's drawing. And again, even now, the schools have become the makeshift camp. No good. What we did was to resume the education within those camps. I think it's again time for us to remind the rulers about it. We did quite a lot of qualitative work, learning how people cope in this. We lost everything in a second, coping a grief. I'm rushing through just giving you the superficial picture because of the time factor. We were the first country to have a national mental health policy. And this is what WHO said. Sri Lanka collectively achieved some strategically important steps, such as developing the agenda for mental health as opposed to psychiatry and bringing public health perspective and multi-disciplinary perspective before translating policy into practice. The repositioning of overall agenda in the right direction was a major achievement. 25 years ago, there was only 20 psychiatrists. We discuss a lot about dead body management, dignified burial, disaster victim identification through genetic testing. Dr. Samath Dharmaratne, I heard saying about sequencing. We did symposium on genetic services. We brought in a Sri Lankan expatriate to talk about it. And this was capturing opportunity strategy. And we were sitting, the IRD was sitting with a huge grant of genetic lab. Some top people were blocking it. We managed to crash it and get the Ministry of Health support to establish that genetic. We talk about ethics of trauma research, people parachuting from abroad, being mindful. People will come for easy data collection. A Japanese group came, they collected blood, wanted to take away. When we questioned them at the Center for National Operation, they said we had an ethical approval taken from Japan, when 2000. So for some other project. But we had to put an ambush at the get hold of. But the funny thing was, one of the ethics committee chairman appointed his son, who was an NGO member, to give expedited review. He gave it. We took him to town to expose him. He had to leave ethics. I gave evidence on behalf of our institution, and we have managed to get ethics, research, everything into disaster management. That is how we captured the opportunity to make a difference for our nation. So I'm rushing because I got 12 minutes. I'll finish definitely, don't worry. Then COVID. Again, we did quite a lot of work. I'm not going to describe this, but I just want to convince you that we did this work. Public perception of, how to manage asymptomatic people. What do people think? Qualitative research. Whether they are better off home or somewhere else. We did preventing COVID-related deaths among vulnerable populations, knowledge and perceptions of about the vaccine. So we did all this outside the health system, all this, and we gave a report to the, again, COVID Center led by General Saben. So he invited us to work. You can see some of the faces, Dr. Mihala Besing, who is the NPP secretary, parliamentarian, chief epidemiologist at that time, founder member of IRD, Anand Vijayvikram, Nilika Madavige. We brought in a team to do it and did a lot of work, and some of them were qualitative work. And you can see from this, we also used the media heavily to get the message across. I gave up such a thing this morning in the news. Don't forget about unseen consequence to mental health. So remember, you all who will be managing will have to confront that challenge as well. So the focus is knowledge mobilization, taking the knowledge where it should be taken to accelerate the impact of what you all do. expanding the impact of academic research beyond academia. That's called implementation science. It's very important to make practitioners and policymakers and bring in intervention to the real world. I'm skipping this. So remember, generally, it takes 17 years to make research into policy and practice. What we are trying to do is to make it less. So my last part of the research talk, I can say, research program, maternal mental health. This is what I was going to talk about anyway, spending more time. But I had to, again, we can't ignore the current situation, and I couldn't simply talk about, what we have done without forgetting the context. So remember, the grand challenge, integrating maternal mental health and maternal child health. It's very important. You all know, I don't have to tell you. Why? Perinatal depression is 1 in 10 pregnancies in the western part of the world, but it's 1 in 5 in low and middle income countries. Depression among teenage pregnancies is 15 to 50%. Huge. And access to treatment, this is the most important thing. 90% of women experiencing perinatal depression in low and middle income countries don't get appropriate treatment. So there's a cost to it. This can be quantified. I have a colleague who is in London School of Economics. We are going to quantify that for Sri Lanka as well. And through other people's work, very clearly shown it's a big issue in Sri Lanka, 1 in 5 anyway, and we don't have access. And there are a lot of mixed method studies, cross-sectional surveys done in Sri Lanka. And again, suicide is a very big issue with maternal mental health. Taking all this into consideration, we had to think going beyond epidemiology for intervention. Improving access to psychosocial intervention has been tested by my colleague Atif Rahman in Pakistan. With all due respect, the ladies in Pakistan are less literate than us. So he used ordinary women, trained, use cognitive behavior therapy to detect and do the treatment. And it is shown that it's efficacious. The culturally adapted cognitive behavior therapy. The WHO adapted its Thinking Healthy program. And a lot of research done. And we, with him, had a hub in our part of the world, funded through NIH grant. We were working on this for some time. The previous government, you can see Nihal Jayatilaka secretary at that time. We were doing things, but then we got a big grant to do this scaling up of perinatal depression in Pakistan, Bangladesh, Nepal, led by Atif Rahman. Nihala Besing and I was the Sri Lankan counterpart. And we had these meetings. We remember, this is very important. We, throughout the project, involved community stakeholders, and we culturally adapted the thing to Sri Lanka. You can see from the picture, they are not just translated. It's culturally adapting even the photograph, drawings. And I told you about capacity building. We brought this Krishani jazz singer to lead it. She got her PhD last week from University of Liverpool, but research was in Sri Lanka. So we did a qualitative study to explore perspective of stakeholders right from the secretary health to midwife. In-depth interviews, 8 in-depth interviews, a lot. Focus group discussion conducted. We use exploration, preparation, implementation, sustainment framework. Again, a qualitative method. I'm not going to go into details. So we looked into the outer context, inner context, implementation science, and we did this large, very large samples, qualitative, 80 in-depth interviews, a lot in Anuradhapura and Colombo, rural. And you can see from this list, MOH doctors, PHM, health administrators, you name everybody. Most importantly, people who had lived experience and people who didn't have lived experience. And we were concerned that the trade unions will not like it. We interviewed them. There was overwhelming support for the public health midwife. to be the agent because they see this patient people throughout 9 months. So it's very easy for them to. So based on this, we did the data analysis again, qualitative work, a lot to discuss. I'm just wanting to show this to you. We identify barriers, societal, community, client characteristic, health system, organizational factors, providers, intervention challenges, trade union characteristics. We also found key findings of facilitators through this qualitative work. So I'm sure you will be convinced. A lot of work on the strength of qualitative research doing these things. Then we develop implementation strategy for integrating this into health system. Again, a lot of jargon. And we published this paper, task shifting or task sharing. You don't need psychiatrists. We can train public health midwives in half a day to detect it. And also give the treatment because they building back better task shifting. And we also published this, nothing about us without us. That is engaging the public. We also produced this teledrama half an hour. It was watched by 100,000 people within a month. I wrote the theme song in YouTube. Even for both those, you can see from this, we did a lot of stakeholder engagement. Even the script, we discussed with people. The song, we discussed with people. We got all this feedback from YouTube. And that's how we accommodated. We presented it in this Mihilia Paura. 150 pregnant mothers got their feedback. So this is the strength of qualitative work and the work we did. We presented it in a professional forum. You can recognize some of these faces. Got feedback. There are no shortcuts for proper implementation. We trained public health midwives students. We got feedback as well. Feedback which is very important. And we produced this document for the WHO Colombo. So, from local insight, national policy, scaling qualitative impact, I showed you. I'm sorry I rushed. I had to do it to show that how this 9 to 10 divide in knowledge can be reversed to teach that 90% of the world to do things. Okay. And we brought in 32 countries in August for this twin congress. 32 countries. I'm the Secretary General, I'm the President-elect. To discuss about, and one of the things were about perinatal mental health. Again, communicating qualitative findings to decision makers is again a challenge. Decision makers don't have too much of time. We have this Gaveshana journal, which is happening for the last 20 years. We use that. We send it to all the parliament. We give to schools. Themed issues you can see from this. Current one is, how to harness scientific knowledge. So all that. And this journal, again, founded by Nihala Besing Sudat Samaravir, the former epidemiologist. And our chief editor now was a research assistant 20 years ago. So that is how we developed capacity. And it's approved by the Ministry of Education. Capacity building is a must. So last month alone, we did these 2 workshops through the Ministry of Health and Science and Technology both to try and get a critical mass across. We also did with the college, Sunil Dialvis, you can see, 1-year training. And we support PGIM, post-MDs, most importantly, research supporting medical administration. There are currently 2 people at Kiel. We are trying to send 3 people in January, and she is also waiting to go to Australia. So we will support. So finally, the Institute for Research and Development, which I represent as the has done all this work, which I shared. And we have local, regional, and international collaboration developed over time. We have brought in a lot of money, funding, competitive. We don't accept tobacco or pharma money. We started from scratch, a long march. We, 5 of us, Nihala Besing and myself, so that Samaravira started from this dilapidated, just single room. Now this is what we are. So you can believe, trust that things can be done. I'm humbled to say that we won these awards for the collective work we have done. And remember one thing, very important, as I told you throughout, our success was because of one thing, teamwork. You saw output, you saw the collaborative ability, you saw members' individual development within the IRD and out. And my final question to you, where do you go from here? Start thinking. Impact, shaping practices, influencing policies, and impacting lives. Research for people's benefit beyond us. Time to think, repositioning the agenda, overall research impact, beyond academic impact, and our mission, unhesitant and unrepentant, is for that. And we need your support. Motherland demands a critical mass of research supporting medical activity. That's my plea. That's your team, managing healthcare leadership wisdom through academic excellence, managerial. Very timely topic and theme. Thank you very much. So please be one of them. I request for you can work with us, you can be part of it, we can have partnership. We will not leave any stone unturned. Time up finished, okay? Acknowledgements. This is the team which build up. This is the current executive committee. This is the research council chaired by Dr. Asiriheva Malagi. You know, she is one of your colleagues. We have a very small staff, but we have extensive amount of network. We are very grateful. As much as I am grateful to Sri Lanka, I am grateful to UK for all these universities. But you'll be surprised, I living in 30 years in UK. Most of my time I lived in Sri Lanka, 70%, and I still carry a Sri Lanka. So very committed and Sri Lanka. So that's where, thank you very much for giving me this opportunity to share this. Some thought-provoking, challenging, and things, but I really do want to think under the current context. We all have huge duty responsibility for our motherland. We need to make a change. We need to cultivate. We need to think about landslide. We need to think about the political decision, though, to change planting. The plantation has to change. Our mountains has to be reforested to prevent this landslide. I won't go into that politics, but that's part of it. Thank you very much.
Thank you very much, Professor Mutepala. You took us from the history to up to now to show that not only the numbers, how the qualitative research will show the in-depth for us to take decisions. Okay, the floor is open for questions. Please make it useful. Asking the professor whatever you wanted to know. Okay, please. From the dean, from the, yeah.
Thank you. Thank you very much. I don't know how useful this will be, but thank you very much for that really enlightening presentation. I was particularly interested in the correlation you drew between the perinatal depression and the low socioeconomic status. What advice would you give, I suppose, moving forward to how research can, really understand that correlation better, because obviously we know that low socioeconomic status has a massive impact on health outcomes and health disparity in terms of metropolitan versus rural areas in Sri Lanka.
Oh, it's another talk. We did all that. Unfortunately, I concentrated only on this. So socioeconomic backgrounds, as you know, not only in perinatal mental health, all the health issues, it's an important parameter. So we have to take it into consideration, and in all our research, we also looked into health economics as well, and not only in this one. So that's the shortest answer I can give. It's very important, and it's very clearly shown. It's under-educated, unprivileged strata of the society has higher morbidity. So that's a direct fact. But there's bit of confounders between education and socioeconomics. Yeah, that's one of the impacts, sort of strategies you should think about making an impact. But more than that, our overall conclusion is that a lot of people are ignorant. I mean, they don't know about it. So currently our strategy is to try and educate people about this, to detect at least. And once it is detected, even if you don't change their socioeconomic environment, by changing the way they think about the life, expectations, how to change. I mean, cognitive behavior therapy is basically dealing with here and now, the way you think. Once it is changed, you can change the emotions and the behaviors. So without making a complete change in the socioeconomic factors or whatever it is, you can still use CBT principles to make them better during their pregnancy. So it's quite complicated, but I mean, you can't say unless this is changed, we are not going to change perinatal depression. No, even if the situation is the same, still we can manage them by changing the way they think and how they deal with it.
This question, sir, now you have been a very frequent figure in the health ministry and health system for last maybe a decade or so. Based on your experience and your awareness about our system, what do you think like now? There's no doubt that the research-oriented results has to be get embedded into our policy making and implementation. So if so, but on the other hand, there's a huge gap in integrating those things into our policy making and implementation. So based on your experience and your reading, what do you think that the most important structural reforms or the changes need to be get into the health system in Sri Lanka?
Yeah. To answer, it's again a long talk, but the thing is, we all know the Ministry of Health has planned for health strategy for 2026 onwards for the next 10 years. So as I showed you from the international thing, there are two barriers. One is structural, but the other one is individual. When it comes to structural barriers, I have to admit that, I say this throughout the world, we have one of the best systems in the world. Public health system, curative system, there's absolutely no doubt about it. However, within that, I have an issue with having this, vertical and lateral, directorates, and them not working with others. That's the thing. That's more complicated by the fact that at times, even though people change from 4 years to 4 years, if a good person comes, things happen. I mean, I'm open about it. If a bad person comes, he thinks he's the person who knows everything. I mean, in spite of all this massive research, we have excellent support from the health secretary, 95% of, but there are one or two individuals saying, no, do it the way on. But I think the solution to that is not blaming them. We researchers have done research for our own benefit publications, and we have not tried to work with the policy planners, the politicians. work with right from the beginning. We produce a hat, and try to see whether he fits into their head. That's why I said not only community involvement engagement, engaging the stakeholder. Right from the beginning is important. We just applied for a very large grant, take this work forward. We actually got the two ministers, health minister as well as science and technology secretaries, to be co-applicants in this application. And once the application was submitted, the next morning I send an email to everybody saying, we have done this, we are waiting for this. They'll be part right from the beginning. So engaging them. They are busy people. And the language you speak should be very different from we communicate among ourselves. So it's the strategy, it's the implementation. But anywhere in the world, as I showed you, it takes time. But I'm very optimistic, malignantly. We can make a change. We will make that change. The current, don't think I'm trying to sort of do a political thing, but current government, because of the links we have and the people there, it's a good opportunity for us to capture opportunistically, strategically, in a good faith. But I remain very hopeful. We will be in a position to take this message, research for people's benefit, implementation sciences. I'll stop there.
Any more questions from the audience?
Thank you very much. Sir, my question focuses on the slide you said that evidence-based and evidence-biased. So when you really want to study something very culturally or country-wise specific, sometimes, the evidence is really misleading us because the evidence is not really representative of our country. So therefore, when you overcome, how do you kind of overcome that challenge? Because as an example, if you really think about the Sri Lankan food and the culinary methods, no country would follow the same. So therefore, when we go and just look for the evidence available, so they are always misleading us. The result is not really representative what we want to study and what we want to look into. So how do you overcome that challenge?
To overcome that is to do more research. So that's my talk here. Do research, publish your local research, publish locally, share, even non-academic summaries. You mentioned about food. I'll come to that. Now, when tsunami happened, all the Western countries said PTSD would be 60%, 70%. We did island-wide mental health survey. It's only 1.9% for the whole country. That's the cultural thing. Because we are a resilient nation, we have been inoculated through many, many things. When it comes to food, I totally agree with you. If you go to our website and see, we have done extensive amount of work on food. We have a national food database, raw food, cooked food. We are making an app. So that's the only solution. So my plea, all of you do research. You have to do research for your MD, others, but don't do it for the sake of doing research. Please commit for it. Don't use AI and produce a report and do things. And once you have done that, please publish it. Please publish it. Share it among your colleagues so that people know that there is a local evidence. And I can talk for the next, 2-3 hours about local evidence. We have produced that. When you talk globally, preeclamptic toxemia, when I was a student, was managed by using something called lytic cocktail, based on small samples done in the Western country. But then this large study, South Africa, Africa, India, showed that the drug of choice is magnesium sulfate. It changed the whole world approach to research. Then white discharge was treated as sexually transmitted disease. WHO recommendation, as you know. Vikram Patel, psychiatrist, one of my colleagues, did a molecular diagnostic study and showed that it's nothing to do with STD, because there was lots of social cost. WHO changed it completely. Then this Thinking Healthy program, Atif Rahman's thing, it's a WHO thing. So research done in our part of the world, even though small, has made a big difference to the Western country. So I strongly believe we have the capacity, we have people, our education system is fine, medical education. We do research, but the attitude is the thing. You do it for your MD. You forget about it. You are not worried about it. After the research, you are fine, you are happy. don't do it. You have a moral and ethical obligation because you are beneficiaries of public knowledge, public money. So my plea to you, let's work together, your college, our IRD. We can make that difference. That's the answer to your question. So make a critical mass of people who believe in it and who walk their talk. Leaders alone cannot make a change. Generals cannot do it. We need a large army. And I hope very much you all be part of it. Thank you very much.
Any questions? Any more questions
Or comments?
or comments?
Sure.
Thank you very much. Wonderful presentation. I have a comment and a question, if I could. The first comment is about the disaster management. So in Australia, we have a lot of disasters, mainly bushfires, but also floods. Your approach to research during and for disasters is very insightful. It would benefit in Australia a great deal to have your perspective because we do not learn sufficiently, particularly the medical response from our disasters. We relearn them every time, which is a tragedy. So thank you for that because the active research you described, in particular with the community response, which is our biggest challenge after floods or after bushfires. So thank you for that. We need to invite this professor to speak to us. And I mean that sincerely. My question though was about the maternity with the Think Healthy program and the public health midwives. To what degree do the public health midwives at some point need to move from the cognitive therapy program to having to actually have prescription of medication? Do you find that very few patients need prescribed medication? And if that does happen when someone's very severe, how does that connection work?
Only a small percentage of people will need medication. Mild to moderate can be treated with cognitive behavior therapy. And if you have somebody severe, then you can refer and you have to refer, definitely. Although I would prefer to say task sharing rather than task shifting. Because when you say task shift, psychiatrists come up in arms, say this is my territory. That's number one. So you don't need. And about disaster thing, you made a very important comment. When tsunami happened, I was going to Gaul with Professor Siribatan. He said, what are you going to do? I said, I don't know. I have absolutely no experience. So he asked me, why the hell are you going? And I said, I'm going to learn. To be very honest, we learn a lot from that visit, from people, how they are reacting, how they are coping, what's to be done. So it's a learning curve over the years. Thank you very much for your comment. More than happy.
You said a comment about that Sri Lanka was the dumping ground of Western donation. I don't know if Australia contributed to that. I hope not.
No.
But if we did, I will clean up tomorrow. But in all honesty, I worry about that because if you look at a country like Australia, we do always consider our Southeast Asian and Southwest Pacific neighbors close to heart. Solomon Islands, Indonesia, Sri Lanka, Malaysia, in particular during the tsunami, where we lost people ourselves volunteering. But I always wonder whether we listen enough before we act about what is actually needed. And there's a lot of lesson there. I'm still in the Australian Army, and we still prepare all the time for disaster relief. But I don't know if we actually have gone back to people like in Sri Lanka and said, you remember the disaster relief we sent? What % was junk and what was actually needed? Because that would be of great benefit. If anybody knows the answer, we can email, because I will tell the government. It's not a problem for me to tell the Australian Defence Force. They will listen. Anyway, but I want to say, if we did, I apologise.
The language was not English, so I'm not going to say anything more than that. It was a different language. But thank you very much for your comment. It encourages. Having said all this, I would say we are still learning. The learning curve doesn't stop. And even perinatal mental health. Thank you very much for your comments. I feel very humbled. about it.
Thank you, Professor, for a very insightful presentation. And there are several learning points for our MPG trainees. One learning point is, I think, always you should be lifelong learner. And also you have to go to the scene and learn. You can't predict what is happening there, but you have to go first, visit and observe. That is that kind of qualitative study. When you see the real scene, what is happening there, you will learn a lot. So I'm really impressive with this interactive learning session, sir. And also the college would like to work with you in the future, the time to come. Thank you so much. With that, we conclude this session. Then we can go to the next one. Thank you.
Thank you very much, our co-chairs and our guest speaker, for taking us through an enlightening and thought-provoking session on a concept which is a dire need of this hour. Let me invite our co-chairs on stage to present a token of appreciation to our guest speaker today, Professor Atula Sumadipal. Thank you, madam. Thank you, sirs. Now, we are moving on straight away to the next item in the agenda, which will be the healthcare innovation presentations, where we have 12 presentations by our medical administrators. Let me invite the panel of judges for this session to take their seats. And the session will be co-chaired by Madam Dr. Leelamani Hevagigana and Dr. Sudhar Dharmaratna, President of the College of Medical Administrators. And the panel of judges will be Dr. Sydney Chandrasiri, Chief Executive of the Australian Institute of Health Executives, and Dr. Kanti Aryaratna, Director, National Program for Tuberculosis Control and Chest Diseases, and Dr. Alan Ludowick, the retired Senior Medical Administrator and former Chairman and Chief Executive Officer of National Authority on Tobacco and Control. Over to you, Madam Answer.
We are moving forward for the innovation competition now. We are having the finalists today. We are having 12 finalists. So we'll be celebrating the creativity, courage, forward thinking, leadership in healthcare. So let us start because we are a little behind schedule with the first one. Actually, because of the disaster situation in the country, we have to, we are not going according to the numbers. We have to get the directors to go and take the leadership in their hospitals quickly as possible. So accordingly, we have adjusted. We are taking number 12 as first, establishment of a short stay unit to enhance efficiency of patient care at District General Hospital, Matale, utilizing available resources and multi-innovative approach. Basnaika KTB, it's your time.
Good morning. Good morning to esteemed co-chairs, the distinguished panel of judges, ladies and gentlemen. I would start with the famous quote of Steve Jobs: "Innovation distinguishes between leader and follower." So this is the multi-innovative project, establishment of a short stay unit at DGH Matale. This is our hospital team. So background of this project is the Matale is the largest district in the central province. The land area is 1,952 square kilometers. And the DGH Matale is the largest healthcare facility, provides healthcare services for several bordering districts as the apex center and the key tertiary care hospital of the district. And it also covers the Kandy, Polonnaruwa, Kurunegala, Anuradhapura district, serving about 600 population. And the district is a multi-ethnic and multi-religious district. And the socio-economic status is bit low according to the country per capita income. So the story begins like this. The routine supervision and the staff interviews revealed that the overcrowding of the medical and surgical wards, casualty wards, and the ENT wards, especially in the casualty day, the bed occupancy rate is more than 90%. Overwhelming workload of already limited staff, causing burnout and impacting patient care. The audit revealed many patients would be discharged within 24 hours if treated with the follow-up plan, like the cases like one-day fever, minor trauma, foreign body, in-ear, and atypical chest pain like things. The time-consuming and costly process of admission and discharge will take more than 24 hours, even for a minor issue. So the high cost of patient and families, both financially and in terms of time spent in hospital, which caused the opportunistic cost. So this is our problem that we have identified. The DGH Matale is facing overcrowding, especially wards like medical, surgical, and ENT casualty wards on casualty days due to unprioritized patient admission for conditions manageable under 24 hours, resulting in staff burnout, compromised patient care, and time-consuming, costly admission and discharge process that burden to both health system and patient and also their families. So for the justification of this project, a significant portion of patients admitted to the wards could have been managed in a short stay unit. So the stakeholder feedback, as the consultant and the doctors and others, so we had the stakeholder meeting, and the patient interview indicated performance for quicker treatment and discharge process. The resource optimization, available space in the A&E, we identified available space and which suit for a short stay unit, which could be reduced the hospital burden, streamlining patient management and discharge. Considering the cost effectiveness, that the recent study who had done which is done in the Kandy Hospital by the Dr. Sumana Sekar and Professor T. Silva, revealed that only the the hotel cost of a patient is about 6,310. So we plan to reduce the overcrowding and reduce the cost of the admissions also. So this is the objective, to establish a short stay unit within the accident and emergency department of the DGH Matale in 2025, with the aim of improving patient flow and care, optimizing resource utilization, enhance patient and family satisfaction, reduce overcrowding in casualty wards, and decreasing hospital admission for conditions that can be managed and discharged in less than 24 hours. So this is our methodology. It was a mixed method approach. So we did the admission discharge process mapping first. Then we did focal group discussions and patient and staff interviews. Then we analyzed the main problems and we did the SWOT analysis to identify our strengths, weaknesses, opportunities, and threats. Then we do the nominal group prioritization of the problems and the operational strategies we diverse and which were implemented. So this is the methodology. First, we did, as I said, the process mapping. Then we did audit and qualitative analysis. Then expert panel discussion, collaboration between hospital director, consultant, and in charges of the planning unit and the other in charges to do the protocols and the SOPs. So we did the process mapping. The existing process was the patient presented to the OPD and the triage was done by the MOPD. Then the second step, admissions was done by OPD doctor, decides whether the patient who should admit to the ward or a ETU or the emergency unit. Then initially the management in the ward was done by the HO or the SHO under consultant opinion. Then the step 4 is the discharge, which will take routinely at least more than 24 hours, because the less than that we couldn't find a discharge process even for a minor cases. These are the focus group discussions we have done. So we did the fishbone analysis to get the cause and the effects. So method wise, people wise, environmental wise, and the material wise, we did the fishbone analysis for this our problem. Then we did the problem prioritization according to the nominal group prioritization. So we found 9 major issues: that inefficient triage process, lack of staff and medical officers, resistance to change, lack of responsible consultant for discharge decision, overcrowding in wards, lack of space for expansion, limited resource like beds, lengthy discharge card writing, and lack of equipment. So then we prioritize the feasible priority issues. Then the one is the inefficient triage process, lack of staff and medical officers, resistance to change, lack of responsible consultant for discharge decisions, lack of space for expansion, limited resource like beds, and the lengthy discharge card writing. So we did the SWOT analysis to identify our strength, weakness, and what are the opportunities and threats that we have for solving this problem. So the implemented strategies to address the inefficient triage process, with the discussion of the expert panel, including consultants and the doctors, we produce a SOP, and the triage corner was started with the help of a triage nurses. The SOP was formulated for the patient admission with the consultant. So in that process, the category 1 patients directly admitted to the ETU, which need the acute emergency care. The category 2 patient admitted to the ETU either or through the MO admissions to a ward. Then category 3 and 4 patients, we tried to admit to the short stay unit and analyze with the help of emergency consultant and the other consultant, which can be dischargeable safely within less than 24 hours. So the second implemented strategy, because I said this is a multi-innovative project, the lack of staff and medical officers. Initially, we started this with the 5 RHOs who done internship recently, because that the key strategy is to optimize existing human resources, because we are lacking of human resources to start a new unit. You know that there are a lot of resistance from the existing MOs and some trade unions to start a new unit, but we know that the importance of this starting of this short stay unit. So we initially started with discussion with the young 5 doctors, this short stay unit, and we started it initially from 7 a.m. to 7 p.m. So some ETUMOs and other staff also resisted to, as I said previously, to this change, but the frequent discussions, supportive actions, and gradually we initiated the hospital admission this process. So we initially not started 24/7. We started this short stay unit from 7 a.m. to 7 p.m. So they agreed. Then the successful opening of the short stay unit done at DGH Mahatale with the director, and then the lack of responsible consultant, again we found a problem, because that the emergency consultant is working in the emergency department, but with the discussions, we agreed that the VPOPD is going to do a ward round in the short stay unit around 2 p.m. Then he can see all the patients and their investigations. Also, the responsible consultants were facilitated with rapid path for essential investigation like full blood count, ECG, troponin I, X-ray and ultrasound scans, etc. So that we can without going to the routine pathway, we rapidly, there was implemented a rapid pathway for the essential investigation, so we could safely discharge the patient in less than 24 hours. So there is a lack of space because we have to accommodate sometimes 20 or more than 10 patients. So we innovatively designed the recliner thing, because we couldn't accommodate all the short stay patients in beds because there's a lack of space. The only the bed, if we added only the beds, there are the 5 or 6, more than 5 or 6 beds we couldn't accommodate there. So we designed a recliner chair. So this recliner chair can accommodate a patient with safely. We did the measurements and the sketching also. Then we accommodate this with the chair also. Then we have find that the lengthy discharge card writing process also there, which could hamper the immediate discharge. So we formulate a short discharge plan also. The results wise, there were 328 and 499 admissions were there. Then in the month of August, from the 328, 242 were discharged, more than 70% were discharged within 12 hours. And the September, it was again gradually rising, and 363 were discharged out of 499. You can see the data gradually that the admission to the wards are reducing, because that we could be able to discharge these people from the short stay unit. From the numbers always doesn't reflect the true picture. We did some qualitative analysis with the staff and the patients. The patients were satisfied because we did the satisfaction surveys, and also the staff in the casualty wards also satisfied because that the burnout is getting less. So lessons learned are the teamwork, collaborative efforts on the leadership, consultants, medical staff, and the critical care staff are the critical for the success of the SSU establishment. And the sustainability wise, the staff engagement and the continuous feedback were essential for ensuring long-term effectiveness. The resource management wise, efficient use of available resources, including HR, to help to maintain the quality of care in spite of limited resources. So the sustainability and way forward, we have expansion plans in the future enhancement for up to 24/7. Long-term, in fact, improve the hospital efficiency, reduce overcrowding, and sustain patient care improvement. The SSU model can be replicated in other secondary hospitals in Sri Lanka. As a conclusions and the recommendation, the innovative solutions like this are advantages for the SSU model demonstrated a cost-effective, resource-efficient way to manage less critical patient, improving overall hospital performance. The SSU model should be expanded and adapt in other healthcare facilities, optimize patient care management. So the innovative action, strong leadership, and motivated teamwork can make the Sri Lankan health system great again in difficult context. Thank you.
Thank you. You have taken 2 minutes more than the allocated time. So I'll pass the question. I'll ask judges to ask questions remaining 2 3 minutes.
Thank you very much for that. I can see that that is an absolutely practical and useful innovation. I just had 3 questions / comments and clarifications more like that I'd like to ask. Firstly, in terms of, and this is because I don't really know the context of other hospitals in Sri Lanka, whether they have existing models for, fast tracking patients. But did you do any benchmarking nationally or internationally in terms of what would be a good short stay unit model to emulate and put in place? Do you want me to keep going, or do you want me to do it one by one?
I asked that question because we in Sri Lanka we couldn't find a proper benchmarked setup like this. Some hospitals is having the similar setup, but we internationally searched some data and the models. So the issue is that we couldn't have any separate space. So we utilized the available space in the emergency department. And because of that problem, because we are having limited human resources and we had the overcrowding of the casualty ward. So that's why we come with this problem. So to address this problem, we get that the multi-innovative approach of that making a recliner chair to accommodate the available space. And we did the triage, and that things are the standard one, because we have to do the standard triage. And then the admission and discharge standard operating procedures also we manage with the local context.
And with those procedures, did you also look at clinical care pathways and whether there was variation in practice between consultants and how they manage common conditions?
Yes, yes.
And would that relate to, in your results, your outcomes, you talk about improved efficiency, enhanced staff productivity, and reduced costs.
Yes.
So what metrics did you use to actually measure those outcomes?
Yeah, we did the patient satisfaction surveys and the staff satisfaction surveys, and we did some qualitative key informant interviews. I showed that some basic thematic analysis we did. So that pathway we got that the high satisfaction, because that a lot of patients are coming to the hospital and they would like to discharge early, because that if they admitted to the routine ward and the routine pathway, they have stay more than 24 hours, because that the discharge card writing and the investigation tracing and those things were taking times in the routine pathway. So to address those things, we formulate this process.
Excellent, thank you.
Congratulations for your presentation and the study. But still, I have one question with regard to the stakeholder engagement. Have you done the focus group discussions with the OPD attendants and the OPD, the patients as well as the visitors?
Yes. That in that part, we found that the patients are more likely to discharge early, because they are having complained that we had discharge because that Matale, then far away places, there are no transport facilities to go there. So the patients also would like to discharge early and go there. So that to address that part, also we did the interviews.
Sadly, we have to interrupt.
And also the staff.
Sadly, we have to interrupt because we have run over the time. We have taken 2 minutes earlier or more, and now we are taking more. So I'm sorry. We are going to abruptly stop the discussion and the question asking this time. Okay. Okay. The next one, please.
Thank you, madam.
Next presenter is Dr. Chandrasena, APRS. His topic is air conditioners outflow of water harvesting project in District General Hospital Ampara. I kindly request all the presenters to manage your time.
Very good morning to you all, dear sir, madam, distinguished judge panel, colleagues and friends. So our topic is, our project is Water Stewardship Champion, how to save clean and safe water. We all realizing these days again and again, particularly in these days, how important the clean and safe water is with the current situation of country. And I'm representing the District General Hospital, Ampara, as the director. So this is our hospital, couple of pictures, and this is how evolution of our hospital. It upgraded to a District General Hospital in 2001. So this is the layout of the hospital, and you can see, sorry. No. So these are a couple of pictures from our hospital, and this is how our hospital developed into a district general hospital. And here you can see the land area, 54 acres of land area. We are keeping at least 1/3 of the land as a total green cover, as a concept of green hospital. And these are some statistics of our hospital. We have 840 beds with current bed occupancy of 65%. This is the one and only tertiary care hospital in Ampara district. And we did a situational analysis regarding high water consumption, especially pipe-borne water consumption is high in our hospital due to large premises as well as large number of patients, and annual water bill estimated to be very high. The number of water units we consumed in 2024 December, 13,777, and it cost 1.6 million Sri Lankan rupees. So we did a SWOT analysis, and we found a lot of things were done in this hospital during last couple of decades by the legendary leadership of late Dr. Lankatilaka Jayasinghe. Rainwater harvesting, wastewater from vehicle service inside the hospital, treated and reused for the harvesting and gardening. RO plant outflow water also reused. And treated wastewater from sewage system, reused. At the same time, we won green building concept of national award twice, and avoid water usage through digitalization. And notices have been displayed, and staff is adhered to the water saving methods. Water system regularly monitored and maintained by the water maintenance unit, and replace washing of floors with mopping. And CSSD water, high temperature water used to clean the drainages and canals. So we understand a couple of weaknesses in our system also. High water consumption, especially in our hospital, due to large area and significant operational needs. And threats also, we have recognized a hospital located in a very dry zone, and which limit natural water availability, and rainfall just limited to three months, like this month in our area. So we understand an opportunity came from one of the healthcare aid, mine employee in my office, to use air-conditioned water outflow, which is a byproduct of air-conditioned machine for harvesting and gardening. So with that, we had a couple of discussions with certain specialists in our hospital, and we developed an objective to minimize the use of pipe-borne water for gardening and harvesting by utilizing the outflow water from air conditioning machines. So we did a literature survey and found out a couple of studies being done on these outflow water of air conditioned machines. Internationally, Egypt, Mexico, and Palestine, they have done a couple of research. And Egypt, they use this, they had done a survey on implementing, utilizing this AC outflow water for harvesting. And Mexico too, sustainable irrigation system. Palestine, they recover the condensate water for air conditioners and examine on that. Locally, we haven't we have noticed any study or any kind of usage of air-conditioned water, except in Buttala, there's a preliminary analysis of air-conditioned condensate water done by a couple of people, and that is only a study on this water only, no kind of a usage for other purposes. So this is purely an innovation. That's why we want to highlight this. So 5 samples were collected from different capacity air-conditioned machines, and we found average outflow of 5 liters per hour. And the total AC outflow for 24 hours, 16,000 plus. And per month, it is close to 500,000 liters. So approximately, it accounts for close to 500 units of water. So we got the permission from Director General of Health Services, Ministry of Health in the early January, and we started this project January 1st. And we listed out all split type air conditioning machines in the hospital, total 298, and we selected 160 machines which are located on ground floors. And we improve the awareness of all staff regarding this project, and AC machines numbered and assign corresponding numbers to water collection cans, which are reused dialyzer cans, plastic cans, and water collection cans were placed under the outflow machines, air conditioning outflows, and cleaning staff collect this water and use for the gardening and harvesting and cleaning. So cleaning service supervisor, as well as the infection control unit, quality management unit, public health inspector supervise this. And we use this water consumption, the pipe-borne water consumption reduced by 312 units in January 2025. So these are the evidences. Our water bill, you can see the bill amount in last December and this January, again this February and March also. Reduction in the water bill, but much more, elaboratively, we can assess the number of water units consumed per patient in our hospital. You can see the reduction is around 5% to 10% throughout. So there are a couple of limitations we identified. AC machines located in storage buildings, very difficult to approach. So we excluded them. And central air conditioning systems, we do have a couple of systems. We excluded those. And the system minimally use period like this rainy periods. So sustainability is the most important part. No capital, no recurrent expenditure, zero expenditure for this one. No need of specialized technical knowledge. No need of special trainings. Use reusable cans as well. That is a plus bonus point for other purposes. And the outsourced cleaning staff maintain it, supervised by the hospital staff, and very easy to scale it up. So contribution to the sustainable water management reduces dependency on pipe-borne water, especially for cleaning and harvesting purposes, and maximize the use of wastewater from air conditioning, which is a byproduct actually from air conditioning systems. And since our hospital premises is large and buildings spread out, so very easily we can use this water and promotes water conservation efforts within the hospital too. So we as a country need to achieve sustainable development goals by 2030. There are two significant goals related to the water, clean water. Goal number 6, clean water and sanitation. Goal number 12, responsible consumption and production. So I believe with this innovation, we can achieve these two goals by minimizing clean and safe pipe-borne water, which we understand these days very important. So I must acknowledge Ministry of Health for giving this opportunity to implement this project, approval as well, and the respected judge panel, as well as the Sri Lanka, the President, sir, and the Sri Lanka College of Medical Administrators, giving us this opportunity to present very important in this very important forum. And my staff, this is a teamwork. We did it in our hospital. I must thank my team as well. Thank you. Thank you so much.
Thank you, present manage his time. We have yes, almost 10 minutes. It's complete our time. So over to judges. You can ask questions at the 5 minutes.
We don't have any major questions, so we can actually save some time because we ran over time last time. So thank you very much. It was an excellent presentation. Very good innovation. You're continuing the good work of the late Dr. Lankajaya.
Thank you, sir.
Audience, any questions to the audience? Anybody?
Definitely. Thank you so much. Thank you so much for asking that question. We do consider that as well. Dengue is a common disease among urban areas, but we remove these cans at least 3 times per day. 8-hourly basis. And we do, entomology surveys on these collected water as well. Thank you very much.
It's a cost effective because you are placing one staff for collection of the water, the salary of the staff and cost. Can you calculate?
Yes, thank you for that question also. Because we do have to clean the drainages and everything as a routine duty, as well as our cleaning staff has to put some water into plants as well. That is their routine duty. So instead of pipe-down water, we use this water. So no additional cost. That is their routine duty. That's it.
Thank you.
Thank you, sir. Thank you, madam. Thank you.
Let me invite number 10 now. LD Patrage will be presenting implementation of appointment system to reduce congestion in common clinic and clinic pharmacy.
So you have 10 minutes time for your presentations and remaining 5 minutes for the questions.
Good morning, judges, panel of judges, ladies and gentlemen. I am Dr. Iresha Patirage, Director of District General Hospital, Mandragala. My presentation is about implementation of appointment system to reduce congestion in the common clinic and clinic farm. So, District General Hospital is the main tertiary care hospital in the district, and we conduct 28 different types of specialty clinics in the hospital at 5 premises. And the common clinic is the largest clinic premises we are having with nearly 175 seating capacity. And in these premises, we usually conduct 3 clinics in the mornings, peak time. So with this, especially in the medical clinics, we get around 500 patients at the time. So the problem came with the overcrowding in these common clinic premises, as well as the clinic pharmacy, with frequent challenging, causing patient discomfort, extended waiting times, as well as increased workload for our staff. So many patients arrived early rather than the given time or the expected time, creating congestion as well as long queues. It's something like a marketplace in the early mornings. And we had appointment system. We gave only the date for them to come. So that was not effective at that time. And this highlighted need for a structured appointment system to manage our patient flow. So it has discomfort with the limiting seating capacity. And since 3 clinics are held at the same places, there were congestion at the single register counter. And staff has to divert their attention to solve unnecessary problems and conflicts of the patient in the clinic premises. And we got a lot of negative comments on our clinic services in social media, damaging hospital reputation. So we started this. Actually, this was a chain of interventions to minimize congestion in the clinic as well as the clinic pharmacy with scheduled appointment systems, and also to ensure that the scheduled appointments are attended correctly to improve the patient as well as staff satisfaction, and also reduce daily clinic attendance by changing clinic schedules. So even we started scheduled clinics appointments, we still face problems. usually around 25 to 30 patients, they never come on the given time. And then they blame our staff not collecting their books or not issuing the cards on the given scheduled times for them. And also blame us, their due appointment times are missed because we have not attended properly. And they gather and block the registration counter regardless of the time given for them. And also another issue that blame us, saying that staff patients get the priority over the given appointments to them. And those who came on the given scheduled times were unhappy because of this situation. And another issue was the time given by us is not tallied with the consultation. So with the time schedule, we started with 100 per hour, then reduced to 80. And again, with these complaints, for the first hour, we even reduced it to 60 and go on. And we used 2 counters for the registration for the main clinic and the other specialty clinic. And also we introduced plastic tray system because the not collecting their clinic books in the given time was a frequent complaint. So we should introduce plastic tray system with the time schedules, and we ask them to put their clinic books in the correct tray. And at the closing of the time, we call to check whether there were any left patients who had not given the clinic books, and after that, ensuring we remove the tray for that time. So after this, they were unable to blame us, saying that we have not collected their clinic books, though they have come early. So this was not happening after that. And for the consultation, we allocated the medical officer dedicated only to see the clinic ward discharges, because for discharge patients, it takes more than 15 to 30 minutes to see one patient. And also staff patients were also directed to be seen by this doctor. And waiting area were organized according to the clinics. And the other thing, latecomers, those who do not come, we take them at the end of the given schedule appointments has been seen at last. So, and for the pharmacy, we arrange seating facilities, about 25 seating facilities, and all 4 counters, we ensure that whatever the reason, all 4 are functioning at any given time. And we ensure that only 1 patient remains at the counter to be served. And some clinics were shifted to the other pharmacy to be taken drugs from, for those who were manageable, because sometimes they are using a lot of drugs with several conditions. And for the staff patients, we requested them not to be in the pharmacy queue, and we collected their drug cards separately, kept in the pharmacy, and their drugs were issued after 2 p.m. So we are not expecting any of our staff patients to be in the queue with the other patients. And we also arrange a priority counter for the disabled, elderly, as well as clergy. So these are some photos before as well as after implementing these interventions. And this is the color tray system that I mentioned. And marking where they have to sit in the clinic. And this is our clinic pharmacy. It's only a corridor. So these interventions helped us to effectively reduce congestion at both the clinic premises as well as the pharmacy. And the limited seating facilities are manageable now because they are coming on due appointments only. And patient flow has been improved and satisfaction for both patient as well as the staff at both premises. And reduce stress on the security staff because they have to control the queue if this has not happened. And so this helped us to reduce congestion, improving patient arrival on scheduled time and ensuring patient comfort. And now we are getting positive feedback from both patient as well as from the staff. And seating facilities are manageable. And the most important thing is now we have patient confidence in our appointment system. So we are still developing and we are planning to go with digitalization and SMS reminders in the future to improve further. And we started this at the common clinic premises, and now all our clinics are using this scheduled time appointments. That's all.
On time completed, well done. Over to judges.
Oh, thank you. Just a comment, not a question. Well done. I think that you've implemented a very practical, sensible, easily, implementable strategy, a range of strategies for the challenges that you found. And I think that it's commendable that you've implemented it in a continuous way. It hasn't been, let's do the study and then look at what we need to do. You've been doing it as you continue the study, which is fantastic. And I commend you on the future plans to digitize the system and move to SMS alerts as well. So well done.
Thank you.
The appointment system is something that we've always had in our system. I think started some years back. And we found that there was difficulties also with transport for our patients coming to, which probably is one of the reasons for not coming on either on time or coming much earlier, and therefore causing overcrowding in our institutions. Did you experience that where the necessary public transport that they were using was an issue that contributed to this?
Yes, in some areas, but with this, and we are giving it's like a rotation appointment. So somebody who gets the first time slot for this month, maybe the next time slot for the other month. And if they are requesting to be given the first time slot, even that is feasible with that. And even for the public holidays, that is the same thing.
That's very good. So thank you for that presentation. Yeah, the questions can be open to the floor, I believe. I will turn it over to the moderators.
Now, Professor Anna, now I think it's a time for tea break, isn't it? Now tea break. Okay, thank you.
Ladies and gentlemen, we will go for a 15-minute tea break and we'll begin the next session of presentations at 11:05. Thank you.
Hello. Number 11, cuff pressure manometer for ward setup. Doctor ID Patirage, it's your turn.
Good afternoon, co-chairs, panel of judges, ladies and gentlemen. This is a practical solution invented by one of my nursing sisters to measure the cuff pressure in a ventilated, mechanically ventilated patients who are managed in our wards. So DGH Manaragala, we have only 5 ICU beds to manage our patients. With this very limited number of ICU beds for the whole district, it's not uncommon for us to have mechanically ventilated patients to be managed in ward setups till we get a ICU bed either in our hospital or somewhere in the country. But we have only one cuff pressure manometer in the hospital that is available in ICU. So it was a challenge to monitor the cuff pressure in these patients who are managing wards. It has noted that accurate cuff pressure is important because if we have not done it, it may have increased risk of tracheal damage, aspiration pneumonia, as well as ventilator-associated pneumonia, either due to high cuff pressure or low cuff pressure. So to overcome this innovation has been carried out with the aim of ensuring accurate maintenance and monitoring of cuff pressure and preventing complications like aspiration, tracheal damage, as well as ventilator-associated pneumonia. So this was a very simple innovation, very cost-effective. We have used only 3 items. That is our old sphygmomanometer, 3-way tap, and 5 cc syringe. That's only the things that we have used. So we used what is available with us for this innovation, and training sessions were conducted on utilization of this method for the ward staff. So this was validated with the cuff pressure manometer available in our ICU. So it measures the values in water centimeters, and we have used the traditional sphygmomanometer, which has mercury millimeter. So we use the standard conversion of watery centimeters to mercury millimeters. And the ideal cuff pressure to be maintained in a ventilated patient is about 20 to 30 water centimeters. So with our invention, we were to maintain it from 14 to 22 mercury millimeters. So it is said at least it should be maintained 25 or above water centimeters. And for if it is to 25, it's 18.7, and we are unable to measure it accurately. So we used 20 millimeter mercury to monitor our patients. So we started this at the last quarter, last year. And with that, we calculated and monitored patients and we got the data from this year actually. Last year, we couldn't collect the data. So for this year, there were 23 patients ventilated and cared in our medical ward 11 itself only. So out of these 23, and 8 were taken up by our ICU, and we were able to transfer 4 patients to other ICUs, including Hambantota, Karapitiya, and Kalam. And we trained our staff to use this new manual. And from the ICU, patients taken up to ICU, we didn't observe any complications like aspiration or ventilator associated pneumonia. Tracheal damage, we were unable to comment on that. So these are the data on the patients that had been ventilated and monitored in the ward while they were ventilated and what were the outcomes of these patients. So Mrs. Nishamani, the nursing sister who was the innovator of this manual, and this is how it has been used. So the advantage over the one that is used in our ICU is we can change the cuff pressure while this manual is connected to the patient, meter is connected. In the ICU one, we have to remove it and adjust the cuff pressure and recheck it. But with this, we can adjust or check the cuff pressure while this manometer is attached to the patient itself. Change is not possible at any time. So we faced some issues when trying to carry out this in the ward setting. There were resistance from the staff because medical wards are already flooded with patients. With the heavy workload, they feel this as an added burden because we expected ventilated patients to be taken care and managed in ICUs, not in the wards. And lack of prior knowledge regarding the importance as well as how to do the monitoring of this coverage. That was also another challenge we faced. So we did continuous awareness as well as discussions regarding the importance of the monitoring of this blood pressure and taking care of these patients till we get proper ICU care. And training of staff done, and there was an added advantage for us because the inventor was a nursing sister. So the nursing staff accepted it rather than we are telling them to do it. So that was an added advantage for us. And also, they got compliments from our consultant anesthetist regarding the patients taken to the ICU, saying that they have managed well these patients in the ward side. So that was a motivation and also a self-satisfaction for the staff to continue this. So this project highlighted the feasibility of low-cost maneuver to monitor blood pressure and ensure patient safety while being cared at the ward. And now the other wards are looking for this, and we are trying to introduce to the other wards as well. Thank you.
Complete on time. Over to Gayus.
Thank you very much. Can I just comment and say it's very inspiring to see female medical administrators involved in this many innovations. So well done. Just a quick question. Apart from the reduction of complications that you observed, were there any other outcomes that you didn't expect that were good outcomes or bad, I suppose, like length of stay time or, I guess improvement rates of patients, anything like that you observed?
Actually, these patients had other complications also, the CKD patients and sometimes septic patients. So, and we have to take care of them till the ICU beds are available. Sometimes it's more than 1 week we have to take care because once we intubated, we can't take it out. So there's ethical issues and people are expecting us to manage their patients, and though it's a patient to us, it's somebody for the family, either parents, child, or grandparents. So we are bound to take care of them till we get a resource, or unfortunately, if not, till they die.
Wishing you all the best for the presentation and your study. I have one question. You were telling you have 5 ICU beds in the hospital.
Yes, ma'am.
And you were showing us the results, the impact. Do you have any time have you thought of about a control? You mentioned about other 3 hospitals, but have you thought about the controls? Because you do it in the 5 beds, but what about the control?
This was not in the ICU, madam. This was for the patients who were managed in the ward itself. So the ICU patients, we are measuring with the cup pressure manometer available in the ICU. That's the proper cup pressure manometer. So we did this for the patients who were managed in the ward because the cup pressure which is available in the ICU, we have to keep it there to manage the patients in the ICU. We can't take it to the ward and measure and send back. So we need to have some other methods to ensure that their cup pressure is also at the standard or accepted level, though they are managed in the ward. So that's how we try to do this.
Still the control group is not there.
No, madam.
One of the advantages is that you're using a mercury sphygmomanometer machine, which is no longer being brought in because of the disposal of mercury being a problematic thing.
Yes.
So we are changing over.
Yeah.
Is there a lot of old mercury sphygmomanometers available in, say, the ones that are no longer serviceable that you can now bring into the system for this? Have you looked at that? And also copywriting this?
Yes, that comment was given to us even at the shortlisting, but still we haven't gone so far. Thank you very much.
We are moving on to number 3. Vijay Tungar, WMTS, will be presenting an Excel-based statistical process control tool for integrated performance reporting, inspired by Salisbury NHS Foundation Trust, UK, and implemented at District General Hospital, Hambantota.
Good afternoon. chairs, panel of judges, and sirs, madams, and my dear colleagues. This is regarding Excel-based statistical process control tool for integrated performance reporting. I learned it from Salisbury Foundation Trust and try to adapt it to our hospital setting. And myself, Pilina Vijayatunga, then my director, Mrs. Jayavardhana, and one of development officers who prepared me the data. Integrated performance reporting is a structured reporting covering clinical, operational, and financial performances, a supportive tool for performance monitoring. They do monthly, support transparency, accountability, and data-driven decisions. Example, IPR of Salisbury or anywhere, mostly almost all UK settings. Then IPR in NHF UK, Trust, SFTU, Salisbury Foundation Trust, electronic monthly reporting covering quality of clinical care, workforce, and finance other resources. It is internal access as well as a public document. And it is used by, prepared by sophisticated Power BI solutions in a big IT setting with many resources, personal resources, and IT resources. So they are in that hospital, they monitored KPIs, breakthrough objectives, and many then they detects performance trends and issues early alerts, then promote evidence-based governance. But in Sri Lanka, quarterly hospital or public health clinical statistics reports with limited or no dashboards and mostly not standardized. In SPC, you identify the process stability. Everything healthcare processes. So identify the process stability, whether deviating from that process in a significant way or not. Then display trends and variations in charts. They usually monitor mean and upper and lower control limit and identify common cause variations as well as special cause variations. This is a SPC chart. I got it from Salisbury Foundation. It is annually for our performance. Usually it has median, upper control, 2.5 SD, and lower control. Then blue dotted identify performance, it's positive concern. Then yellow, negative concerns. And they also give a target also. This is a sophisticated system. We need at least 20 units, 20 monthly points, and prepare this automatically. And they give the comments whether it is a common cause or special cause variation by the expert. Then the importance is it is a standardized, make data more meaningful, visual identification of deviations easily, then supports planning and accountability. In Sri Lankan setting, it's mostly paper-based or maybe simple Excel files, graphs, maybe bars, pie charts, even tables according to the preference of head of institution. That is the most difficult thing, according to the preference of the head. Then quarterly manual reports with tables or data sheets. Limited use of trend analysis or other SPC related basics, therefore mostly missing early interventional opportunity. So my innovation is developed during overseas training at SFT, then practical low cost or zero cost design, manual data entry with semi-automation, maybe more advanced features than SFT charts in certain aspects. This is a simple, this is the table. You can enter 250 indicators. For example, we have no 20 data points. Usually we have annual data points, monthly annual data points. But the thing is, and if you are waiting until things come statistically significant, you will lose the game. So you want to develop early alerts. So in that, we have only 12 data points, annual 12 data point, monthly data points, January, February, like that. So we enter like orthopedic major surgery 2024, orthopedic major surgery 2025, monthly data. Unless you want to give it a table, enter data appropriately, systematically. If you make, for example, Vijayatunga, I can write GA or GE, then the computer can't read. Like that, you want to put in a standard way. Then with the drop-down menu, you can select what the indicators you want to select in a meaningful way. Then it will take, then this is the one. For example, this blue dotted line indicates 2024. This is orthopedic same day admissions and discharges in my hospital, Hambantota. This is blue line 24. Then I gave a target also. We can give a brown dotted line. We can even split into the target according to series and pattern something. That brown line target. Then blue this line is yes. If the very low, 80%, okay, it can be 70%, 90%, any for upper level, any number. Then it will show. Then it will also like effective 4 points, because in a statistical significant control process, control you want 6 data points, but I got 4 points for earlier. Then below upper with there is. Then this is another one. For example, orthopedic major surgery. 2003. Then, if you select meaningfully, you can control a bundle of data. Whether the relationship. For example, data right. Then, this is cumulative. Orthopedic major surgery. So surgeon is performing well. There's a big shift, upward shift. So this is a simple mechanism, because I heard even there are lots of software, anything, because I learned something Excel. I know only Excel and Word. So that more than that I don't know in computer. Excel I learned it in 2010 in Peradeniya University for 1 week course. They give this some, and I try to practice, but it's losing my knowledge with time and age and everything. But it's a good one to show these templates to developers. So this is a theory of adaptable solution. Then for hospital decision making can be used in public health, dengue and anything, monthly data. They can be used more self-monitoring settings. Roll out in large hospitals, software developers, IT people, bioinformatics come get these templates and try to improve. Because this is a simple chart practice in UK everywhere, Excel graph. We develop it, I develop it more than that. I feel, I don't know. And don't wait until sophisticated IT systems to come. This is the problem in Sri Lanka in our ministry. Wait until every sophisticated things come. No, may come or may not. Start with small and simple but standard solutions in an organized way. For example, name, standard way. Then acknowledgement to my teachers and mentors at SFC UK, PGIM, Invoice and College of Physical Administrators. Special thanks to Dr. Peter Collins, my supervisor, Regional Integrated Care Board Devon UK, Dr. Dr. Chief Medical Officer, SFC, and Dr. Brent Brown, Clinical Governance and Inclusion. He was the one who showed me this pathway. Try to do it. Thank you.
Thank you, Dr. Vijayatunga, elaborating this kind of topic today. The judges, over to you, can ask some questions.
Oh, thank you. Thank you very much. That's very impressive. Thank you. I guess my question is, this obviously has a lot of potential for scalability. So what is your plan for how this can be rolled out wider and across more indicators instead of just admissions? You know, so if you compare the major surgery trend, are you able to then relate that to complications and all sorts of things that gives a comprehensive picture of what is happening?
Almost all data in a monthly, if we are coming this data for monthly, maybe if the developers, you can say daily data, weekly data, monthly data, we can do it. The thing is, I have developed many, because I have only Excel knowledge, many templates, but the thing is, why we are not taking simple solution? That is the thing. We can do it very easily. Simple thing, this 5 hospital we are trying now, we put it almost all data set. Then another hospital can do. Then if we have this rollout in the national level, then they can develop like in UK targets, hospital target. Then put that hospital target above like that. We can do a lot of things. It's a simple thing. That is the thing. It has many data sets like surgeries, admissions, discharges, financial things, dengue, anything you can put. It's a simple mechanism, what they are doing. So,
I don't have any questions, but I'm really would like to comment about your presentation skills. Excellent presentation skills.
There is time. I think I will let the audience, because
I mean, what about the audience? Would you like to ask a question? These are your colleagues who are doing this. So can you redo? Do you want to know how to it be done, or the limitations, or you want to ask any questions?
How you are utilizing your human resource to enter this data?
because we are getting these data, our planning unit has almost all these data, development officers. I have just give the standard name without spelling errors or other error and given space. Then monthly, for example, monthly admission. January, February, it's the same table you can enter. Then major surgeries, minor surgeries, everything, monthly data, the development officer or MRO can do it. Because we did it in our hospital. Now we are in the field, and I discussed with our director, and she agreed, and she is very interested to discuss these things with the consultant. Their performance, for example, orthopedic, they are performing well. And we want to just identify whether our process is stable. That is the only thing. If process is stable, that's all. If we are positive, keen, we can improve. But we should make sure that it is not going down, negative trends. Then everyone should be responsible for if it is a process is going negative.
So I have 2 questions. Are you using Excel for this data entry?
Yeah, because I have no idea about other computer. I know what only things is that, but
Yeah, another thing is, so I was a deputy director in Teaching Hospital Particular. We have developed a Google Studio with the data entry with the Google form. That's how the staff are doing the data entry by their phone. So we don't have each and every unit computers with the internet. We have computers, but we have all the wards have computers, but with the internal network, that is with the HHIMS. So we don't have the internet. So for this purpose, we need the internet. So that's what our staff usually they enter the data by the mobile phones. So how you are collecting the data? Every day we are collecting the data like admissions, surgeries, minor surgeries, clinic number of clinic attendance, OPD attendance. Like every data we are collecting every day. They are entering the data by mobile.
so practically, only thing is we are collecting these data. Why we are not using this to right trend? That is the thing. So monthly data in the paper, just put to Excel. IT people, experts can even prepare a phase point, phase 4 point. So we want to think that our IT people, bioinformatics doctors and administrators come to the common platform and think about simple solutions. Otherwise, we are going in a wrong direction.
Thank you, Dr.
Thank you.
Jitendra, time is up. To acknowledge Dr. Sidney's question, I think you can get the data regarding complications from via infection control nursing officers level boards, and they will be sent to the planning unit, so that the data will be available. Okay.
Okay, I think we are moving up to number 8, and Jayawardena DBAS will be presenting implementation of allergy wristbands and identification cards to improve patient safety in hospital settings.
Good afternoon. Dear present, my dear judges and my dear colleagues, madam sirs and my dear colleagues. Innovation of allergy alert wristband. Be allergy aware and save a life. Definitions, I will just go through a quick definitions. What is an allergy reaction? An allergy reaction occurs when the body immune system overreacts to a harmless substance known as an allergy, causing hypersensitivity. And what is an anaphylaxis? Anaphylaxis is a severe allergic reaction, severe form of a hypersensitivity, which needs immediate life-saving treatment. Just to refresh your medical thing, introduction, every allergic reaction has this possibility of developing into a life-threatening and potentially fatal anaphylactic reaction, which can occur within minutes of exposure to the allergen. Some people are more prone to develop anaphylaxis. Persons who had developed an allergic reaction to a medicine, vaccine, or a food previously can be more prone to get anaphylaxis. Some people without any such known risk factors would have developed anaphylaxis for the first time. This stretching thing, we just know that it is the allergy, but it can go into an anaphylactic shock even. How to reduce the occurrence of allergic reactions? Prevention, actually identify triggers, whether they are prone for a specific food drugs or environmental triggers. Avoid allergen exposure with documentation, correct documentation, having proper allergy alert system to flag patients with known allergies, ensuring that the staff members are aware. This is our innovation, allergy wristband. This is what we have developed. It's just a wristband, but saving life. Description of the project. How was the idea was brought up? Known or newly diagnosed drug allergies were recorded in Sri Lankan hospital settings. But even though we have come across few deaths were recorded due to drug allergies and who have developed allergic shock, anaphylactic shock. Further, in our hospital, few adverse events reports were also recorded. Allergy incident in surgical ward reported in August 2023. Patient overview, patient with a known allergy history, specifically to the antibiotic coamoxiclav. Incident details, allergy history was recorded in the BHD. However, patient has received the same antibiotic the patient was allergic to and has developed an acute allergic reaction. The same thing has happened in May 2023. Patient admitted to the surgical ward to undergo a minor surgery. Patient has given a history to allergy to coamoxiclav from the beginning, even in the consultant's scanner sheet, private sector, and admitted to the ETU, giving the history, admission to the ward, and it was also written in the BHD front page and also in several other places, including the drug chart in red ink. And in nurses' notes, the message was communicated several times in writing during the handing over and giving over process. But you can see here, the allergy was given at the history chart. In the drug chart, the allergy was written. And in the pre-operative checklist also, in the red ink, it was written like he's having allergy to coamoxiclav. But one house officer has written in post-operative notes ordering coamoxiclav IV to a clean minor surgery while she was working at the operation theater, because they are writing the op notes at the theater. When patient was brought to the ward, one nursing officer has given, just looking to the op note, given the IV coamoxiclav to the patient according to the post-op notes. Within 1 to 2 minutes, patient has developed anaphylactic shock, died within 10 to 15 minutes. A court case is going. SLMC case hearing is against a house officer, and few other departmental inquiries also still going. So lessons learned, we thought of need of a standardized allergy alert system to a like allergy ban to prevent similar incident in the future. This incident was thoroughly discussed in the work improvement team meetings, where individual experience of nurses and doctors in the surgical wards were shared to identify areas of enhancement. Recognizing the critical need of improvement of allergy awareness, and the team proposed a practical solution. Allergy risk tag was first introduced. You can see here, introducing a similar risk tag clearly has a named patient of the patient's known drug allergy. But it is not very user-friendly. And this was discussed in the steering committee meeting held on February 2024, and allergy wristband and the patient identification card introduced to the inward patients in the hospital. Objectives achieved: wristband aims to enhance communication among healthcare providers and ensure that all staff members are immediately aware of any existing allergies, thereby reducing the adverse events in the future. To enhance patients' awareness about the allergy condition, to provide effective and efficient healthcare service to patients as a hospital, and be a hospital with the optimum patient safety. Implementation of the practice under this project, different activities are carried out as conducting training programs for hospital staff, and allergy wristband was introduced, where an allergy wristband to the identified patient's hand, which has the IV cannula. It is the most important thing, and enhance patients' awareness about their health condition. Allergy card with a QR code is given to the patient with the when the patient is discharged. An allergy history is recorded, and it can be received by scanning the QR code, retrieved by scanning the QR code printed on the back of the allergy card. Project was implemented during this period timeline, and pilot project succeeded and showed better outcome. This is the starting date of the pilot project. And this is the wristband, main resources for allergy awareness, an allergy wristband, and the laminated identity card with the QR code. This is the QR code we have introduced, and the allergy medical ID card, giving all the details. Results achieved with the practice: none of the deaths have been recorded due to drug allergies in our hospital, and the healthcare staff was able to manage the situation properly. We provide effective and efficient patient care as a team by reducing prescribing errors. Allergy patient can be identified easily without checking bedhead tickets, and consultants and medical officers can prescribe drugs easily. Sustainability of the project: 500 reusable bands are used for this project. When the patient patient is discharged from the ward, the wristband is collected. We have secured sponsorship to procure the laminated machine and initial supply of 12,000 cards with ongoing provision of custom designed card. We have purchased QR Office app, which facilitates the QR code allergy patient database. Conclusion. This process helps to recognize the effects of medicine, allergy, drug sensitivity, side effects, contraindications, and side reactions, adverse reactions. So it helps to reduce the number of allergies recorded in the ability to control deaths due to drug allergies. Further, hospital can provide effective and efficient patient care for the patient in Hambantota district. Thank you.
Thank you very much. You kept to the time. So it's the panel of judges first for asking questions.
Thank you very much. Again, very practical, sensible, well done. How does this compare to what else is being done in terms of allergy management at other hospitals in Sri Lanka? So how does this compare with any other practices that are being done across Sri Lanka?
Actually, the practice is that we are taking the history, allergic history, and it is written in red ink as I showed in the BHD in the front page that patient is having the such allergy history, and also writing it in the drug chart. But it is not very practical thing that any error can happen. Like previously, I have showed that two incidences that it has occurred. Not only the two incidences, there may be more. There may be more. Thank you.
Bit of the patients, but in a way that it's also that as we discussed yesterday also that it could be replicated in the other hospitals, other institutions, and by the other member of the other members.
Next session, I think past President Dr. Alman is there. I ask you to chair the session.
Till the co-chair takes the place, I will invite Rajab TSRTR for the number 2, establishment of a dedicated pension unit to minimize delays in first pension payment at RDHS office Kalmune.
I'm Dr. Rajab, anesthesia and base hospital treatment. This is the purely administrative topic. I'm going to discuss with you all. It's a study we have done in the RDHS of establishment of dedicated pension unit to minimize delays in first pension payment at the RDHS office, Kalmune, Sri Lanka. Though it is in the RDHS office, can be replicable to the other non-health departments also. So this is the study. Based on the introduction, actually, pension is a social security system for the entire population. And there was one study was done in Sri Lanka. There they have identified the factors why it was delayed. One is the errors in delays by the applicant, inadequate staff, awareness and negligence, and weak coordination between departments such as Department of Pension and Divisional Secretaries. Now, what is our problem? The problem with the RDHS office Kalmune, Sri Lanka,
many retiring healthcare employees face significant delays in receiving their first pension payment. So when we are quantifying this issue, from October 2023 to September 2024, out of 49 pension files, 42 were delayed, ranging from 2 months to 7 years. It's a big problem to all our retired staff. So due to that, they face financial hardship, emotional stress, and bad impression about our RDHS and unsatisfaction. So we have made this problem the objective to establish a dedicated pension unit within the RDHS office to minimize or eliminate delays in the processing and receipt of first payment for retired employees. Now, so from this previous study, courses we identified applicant side, staff, and process side in the inter-institutional side. From that, we have extended our study with mixed study methods. We did the structures, interviews, questionnaires, and review of the 42 pension files that had experienced delays. So we found each and every factors, what are the root causes in these all factors. So in the applicant side, incomplete documents, low awareness and late submissions, and staff and process side, we found inefficient training and no checklists and rework cycles. And in the inter-institutional level, we found weak coordination, communication gaps, and low escalation paths. Now, with that factors, we did some intervention with brainstorm done with our stakeholders. So what are the possible intervention we can do? So we have done a brainstorm with them, and we did that intervention. So did the pre-retirement briefings and counseling sessions with all the applicants and application and guidance for them also. And we have started a dedication pension unit there. And we have initiated or created SOPs and checklists and training and supervision also done to our staff. Coordination meeting and escalation matrix and notification and tracking also done with the other department also. So with that intervention, we found these outputs. We've got staff trains were given and standardized checklists and pension application forms and guidance and SOP were created. An awareness program was conducted, one-to-one interview conducted, and dedicated pension unit was established and strengthened IDC. It means interdepartmental coordination and improved tracking also done and continuous supervision done. These are the outputs, and with that, we found these outcomes. Motivated staff, then there was the delays, reduced delays, and improved responsibility, and improved accountability, and improved satisfaction and trust. These are the feedbacks we got from all these applicants and staff side and in the department side. And this is our KPI, key performance indicators, percentage of delay on pensioners file. So before intervention, that was 86%. 42 of 49 out of 49 pension files were delayed. It's around 2 months to 2 years, 7 years. And after intervention, that delay was reduced to 34%, 10 of 29 process within 2 months. So impacts, what is our impact? It is administrative, innovative, process innovative things. So it can be replicable to national level, and there will be a better trust in public service among public. So these are the analysis we have done from these root causes. You can find out it's applicant related, staff related, external institution related, and mixed related. All these total 42 and 100%, and staff related side, lack of proper knowledge is the main. Lack of proper knowledge is main in staff relatives. That is why we have given a very good SOPs and checklists and staff trainings, everything we have done, and a high workload and poor attitude and poor documentation and other things. And analysis continuous applicant related there was an incomplete application form. So that's why we have given one-to-one counseling with our staff. And other institution-related courses, lack of coordination, pension department software delay information from other department, and pending inquiries. And what are the innovation highlights on this study? There was a dedicated pension we have started. It is the first RDHS level systematically assessment and release. So we have to thank on this situation to our PDHS. We gave this permission to start this dedicated pension unit. And it is a proactive and arrangement, because we are all Sri Lankans. We are mostly prone on this reactive process, but it is a proactive arrangements for pre-retirement engagement. And we did the meeting and counseling and before retirement. And there are standardized checklists, SOPs, and defined job roles for accuracy we have created. Everything has done. And still it is streamlining and going on. And strengthen interdepartmental coordination mechanism also we have done with continuous collaboration, continuous meeting with stakeholders and everything. And it is replicable and scalable as a national level model. These are applied principles and models we have done on this innovation, PDCA cycle, as you all know that for this continuous monitoring and improvement. And system, because though we have a goal to achieve this, system will run everything in the long-term way. And we minimize the waste and reworks through this lean management system. And it is a Donabedian model because it's involved all structure, process, and outcomes. And it's a human-centered design, all empowering applicants through awareness and counseling. And it is a sustainable, and it is very much important for our situation of this country's economic level. So in economic, social, and environmental, in a triplet base, what we can see, economic level saves some money and time. And social sides improve lives and trust. And environmental side is reduce the waste and resources. And these are the checklists and questionnaires what we gave to the applicant side. And this is the pension application SOP we have created. And these are the activities what we have done. Problems, brainstorming of staff awareness and face-to-face guidances, and face-to-face guidance and new pension units. And conclusion and recommendation, this administrative process innovation improve the timeliness and quality of pension services while optimizing resource use. It is recommended that this model be applicable to ensure smoother transition for retirees. These are our references, and thank you so much.
Yeah, thank you, Dr. Rajab. Actually, well presented a timely, important project. It's first actually over to the judges. So, and then thereafter the audience, you can make comments and questions.
Thank you. That's actually something I think very much needed by our, especially the health sector. You know, we know the delays that we have. I retired also not too long ago, and in truth, you quite rightly pointed out that it is often the personnel involved, right? Not only the applicant, but the people handling the file. It is their motivation and their, you know, I mean, I was fortunate. There were certain ladies in our in the relevant sections who pushed it for me, and in a matter of you know, few months, there was an initial delay because sometimes to get, as you said, because it's cross-cutting.
Yeah.
And some other departments, other hospitals, for example, have to issue letters saying there's nothing pending. All that takes time. So we have to see, because it's a very useful thing and it should be replicable. We have to see how we can expedite everyone so that these things can be done online.
Yeah.
You know, otherwise this moving of these manual files from place to place takes far too long.
Actually, sir, we have initiated a software system in RDHS Kalmai that is called R1. All the documents they can include it, upload it into that R1 software. Through that, all the documents won't miss there and it will be there, and all the staff can, all the dedicated staff, they can retrieve everything and they can continue this process. So no, nothing will be lose the documents, everything.
That's very good. I congratulate you on doing this. I hope that we'll be able to move it forward. If you can present this at a national level, maybe at one of the directors' meetings, and it has to move beyond the health sector, obviously, to every other department, government department as well, so that we really meet the needs of those who are, ending their careers.
Thank you, sir. Thank you.
Thank you. Agree with the previous comments. Very relevant, very applicable. Just a question on the economic savings that you mentioned. Do you have any figures that you collected in terms of the cost of establishing the department versus how much was saved as a result?
Really, we didn't do any cost analysis, but we have utilized our staff, a normal working staff, and initially there is a cost because we have done a counseling and everything. So because of that, we have to gather all our applicants and everything. Then we have to do some, refreshment and all trainings and everything we have to do. Initially, we have a little cost, but after that, once it started, it is as usual normal setup. So its cost is not a very negligible cost. Economical wise, it is very wise. Another thing is, most importantly, the applicants are very satisfied because they have respected, they have dignified, they told that we didn't get this type of counseling or meeting ever before like that. We are respecting them because we can't neglect them as a retired people. You can't come in again like that. We can't neglect them. So that's what we have done. It was well appreciated by the applicants.
It may be feasible for using this unit in a institution where the personal files are managed by in a large amount. When we are thinking about a small institution, it's not practically feasible.
Yeah.
Can you get an idea? Okay, how many number of files subject clerk managed before, like doing this? Roughly.
Actually, this department, pension department unit, we have.
Not about the pension department.
Yeah.
Before we established the unit, pension
Yeah,
department, other personal file staff, how many personal files each and everyone manage roughly, not exact amount. For example, if you take medical officers, there may be one or two. Everybody may be managing for about 200, 300 or something else, or less than that. I'm just to have an idea.
It is around per year, it's around 40 to 50 files.
That is the number of
files
moved.
Yeah.
I'm asking each personal file managing staff.
Yeah.
How many files they were each managing totally? I'm just asking, not the pension files.
Yeah. So
Files
each file
per-
is actually, there are many subjective things.
I'm asking just,
Yeah,
just
I
we
think,
have
we will have to clarify that matter over later because we have to move. I'm sorry, really sorry. You can answer him personally also later. So because we are behind time. So let us, thank you very much.
Thank you so much, madam. I have to thanks on this time our RDHs also.
Yes.
And our team.
Yes.
And our RDHs team also. Thank you so much.
Okay, thank you, Dr. Rajab. Actually, that organizing a project, actually improving the efficiency, and not only that, actually that giving counseling, even actually that it will be worthwhile for the pensioners. Okay. Then next one, foresee the fever, establishing a continuous care coordinating center for acute fever patients at National Institute of Infectious Diseases. It will be presented by Dr. Pereira, MHMPS.
Good afternoon, chairpersons, good afternoon, judges, and good afternoon, my dear colleagues. I'm presenting on behalf of my team at NIID. I'm a general physician, by the way. So, there was a problem of identifying early stage viral fevers and other fevers because we as IDH, we are like on daily basis seeing a lot of fever patients in the OPD in the outpatient department. So we have to manage non-severe and the outside manageable non-severe patients in the outpatient department. So in response, a need was identified to streamline outpatient care by early detection of warning signs, optimizing hospital admissions while ensuring continuous monitoring and timely interventions for non-admissions. So our key objectives of the project was to ensure early detection of warning signs and to expedite admissions to prevent complications and to minimize unnecessary admissions and to establish a nurse-led continuous care pathway for non-admissions. So we have come up with this concept of 4C4 fever, which is a framework that we can reduce the gap in the current care model. So we can integrate the community and the preventive care as well with the curative sector. So we serve patients who present with the fever within the first week of onset, and we streamline them their care pathway, and we are establishing a two-way communication via a digital platform which enables patient registration, remote symptom reporting by the patients themselves, who has, by the way, who has IT literacy and computer literacy. But for the people who don't have that literacy, the paper-based form will be continued. This allows healthcare staff to monitor patient inputs in real time to trigger early escalation if warning signs emerge. So this is our flow of the care pathway. So all fever patients who come to the OPD, they are being triaged by a nurse, experienced nurse. If they have the warning signs, which I will share with you in a minute, they will be, if they are unstable, they may be directed for direct admissions. But if they don't have any warning signs, they will be directed to the medical officer for their screening. The stable patients with warning signs, they will be taken up by this 4C4, and with the full blood count, they will be again sent to the medical officer, who will assess whether the patient needs admission. If the patient doesn't need admission, the patient will be returned back to the center, where the nurse who is in charge will advise on rehydration, health education, and plan the next appointment according to the doctor's prescription. So this is kind of a safety netting. So you send the patient back to the community, and then the patient don't have to come back to the OPD with the OPD sheet or the OPD number. They can come directly back to the 4C4. Thereby the nurse can, depending on the current condition, can refer to the medical officer accordingly. So these are the warning signs which are actually recommended by the WHO, and as well as talking to our senior clinicians at IDH, we were able to build up our own warning signs as well. So the main thing is we screen or we take in the patients who have fever, arthralgia, myalgia, mild headache, but without respiratory, like major respiratory symptoms. So because respiratory symptoms, if they are prominent, those patients will not be triaged in this center. So this is the registration of the blood collection area, and this is the hydration area. And this is our separate investigation request form. And this is how the nurses on paper, how they document the vital signs. And these are the instructions given to the patients when they return to their community. So this is the other form where if the patients have literacy, the IT literacy. For non-admissions, the digital platform enables patient registration, remote symptom reporting, and two-way communication. So this is our 4C4 Fever Hub, which was designed by us, white-coded actually with HIPAA compliance. And we have separate access to patients and a separate access to the staff. It's available in all 3 languages. So if you are interested, you can scan this QR code, where when the patient comes to the OPD, these QR codes and these warning signs will be displayed to all the patients who are waiting in the OPD. so that they know when to, like, they should not wait until they get their opportunity. They can go straight way to the 4C4 so that we can minimize that waiting time. So this is the nursing or the health care dashboard where we are like alerted about the morning signs, missed appointments and no-shows, so we can contact them via SMS or via phone call. This is the main dashboard. Now, for example, now we have 4 active patients and we have 4 follow-up patients and without any warning signs. So this is a summary. So we can add new patients when they are registered, and this can be integrated to the EMR as well. Once we don't have an EMR at the moment, but soon we are going to have it. So each patient will, in each patient's record, the most important thing is the symptoms. The warning signs will be red flag, as well as the platelet drop will be red flag automatically. And this is integrated to the patient's port as well, so that when the patient is logging in any symptom, it will be automatically displayed on the healthcare portal. So this is the patient portal. It is again on 3 languages. They can log their symptoms, upload pictures of signs and symptoms and blood reports, and health education material can be accessed. They can see their details of their own visits as well. So this is a symptom checker, which they can log in daily or maybe a couple of times during a day. They can take a picture of the full blood count. If they do it as outpatient, they can upload it, and everything will be shown to the healthcare portal automatically. So our key goals are early identification, continuous care, and to establish a structural referral and follow-up system, data-driven decisions, and for research pipeline as well, and improve outcomes and community awareness. So since last October, we actually developing, we are, doing some trial and errors, trying to find, the mistakes that we do. So we are learning. We are in the learning process still. So we had like 66 visits for the last 3-4 weeks. So way forward would be, we want to establish a GP network first in our vicinity, so that the GPs can access this system, so they can refer patients straight. And we are also going to have some display boards along the hospital as well as the OPD, and a feedback system, especially by a feedback box. And we are always learning from my experience. Because of the HIPAA requirement, we have to keep our staff to train. So these are email, telephone, and the official Facebook account. And this is the patient portal that we showed you earlier. So I would like to thank my director, who has been kind of really our guiding star, to be honest, in the hospital, and our team, including the senior clinicians, the special grade nursing officers, and the other nursing staff, the doctors. So this is still in the pilot stage. It's not more than 1 month, actually. Thank you very much.
Thank you, Dr. Perra. You have completed actually before the time even. No, yeah. So then actually Dr. Perra is the consultant physician at the NIMH. So then it's glad to see actually the other consultants are actually also presenting here. So then others also that will invite our directors to actually encourage their physicians and other consultants to do the researches and presenting our sessions. So it's over to the judges.
Thank you very much. Well done. I think you've got 2 innovations in one here. You've established a way of keeping patients essentially out of hospital, managing community care. And you've also introduced a patient portal as a dashboard, which I'm just thinking whether we should get you to touch base with the person that did the Excel spreadsheet, combine that and have a dashboard that uses that data. So well done.
Congratulations. And I also 100% agree with Dr. Lalbana Bithia. the teamwork. We can see the teamwork. And I just wanted to know the patient portal is being uploaded by the patients.
Yes, madam. So patient, they have a computer or phone, they can upload, but they are given a paper format also. We want to just learn how our system is, user friendly. So we don't know because we are just still trying.
Right. That's what really I wanted to know because everybody will not have a computer or a smartphone. And so it is being assisted by the paperwork as well as by the staff. Okay, thank you.
Another 3 minutes time, actually, for the audience, if you have any comments.
Yeah, I just think that going forward, of course, you are a National Institute for Infectious Disease, so fever screening like that would be very, very useful for an institution like yours. But have you thought about comparing this with some of the other studies that are there? Because from time to time, when dengue crops up, for example, we also have in some of our other institutions where they kind of separately handle this so that admissions can be, reduced. Otherwise, every patient gets admitted during a dengue season, for example.
Yes, sir. Thank you. We had this fever corner concept for some time, but this is kind of another step forward from the fever corner. So, and this is kind of a nurse-led center. So that is what we want to compare. So fever corners are there like many hospitals during epidemics. So by that time, I think we will be able to compare and it's not about managing patients outpatient. It's about catching the most important patient. Because this is the reason why we started this, because we had 2 deaths in 2023 and 1 in 2024. Because the patient came to OPD and was waiting for more than 6 hours. So we were really worried about those 2 deaths. So those are the 2 deaths that led to this kind of.
Thank you.
Anyone wants from the audience 1 minute more? Okay, we are saving 1 minute, I think. Thank you very much. Thanks a lot.
Thank you.
Oh, we are moving on then. Dr. Malwatha AK will be presenting innovation number 5, from clinic to community, a low-cost integrated approach to childhood obesity and NCD prevention at National Institute of Infectious Disease.
Esteemed judge panel and ladies and gentlemen, I'm one of the clinical nutrition physicians worked at NIID. We were just working with this hybrid platform, what we thought very useful in our patient care, especially when it comes to the pediatric patient care. This innovation actually came as a solution to a practical problem we had. The practical problem was we were getting patients from the school for their obesity, fatty liver, and multiple metabolic related issues. Especially through the school medical inspections, they are given a white card for they have to go to a nutrition doctor or physician and get it cleared. Okay, we are under some kind of metabolic coverage. So usually the story ends there. They come for once because they are compelled to go for a clinic with regard to their obesity or something, and they never turn up. So that was our experience. We as clinicians, we know, my friends, it is not possible to do a behavior change or take any step for NCDs in one visit. So we had to do something. We were compelled to do something. So this is that. So the childhood obesity is a severe grade problem, and it is linked with the low caregiver awareness. So they were very weakly followed up. We saw that caregivers had, especially the parents or whoever companies, maybe grandparents, had so much of other problems to prioritize rather than the NCDs in their kids, which is not a great problem as they will see. It is not an immediate vicinity problem to be found in the immediate vicinity. So they always overlook that, and they have so many other things to prioritize. So we were very strongly believed, and our director, Dr. Sandanayaka, and our team was very helpful in creating this family-centered hybrid platform to follow up these kids. So there's needless to talk about the extent of the problems, you know. So that is the leading cause of death in CDs. If you don't do anything, especially at the childhood, you will get more and more adults dying out of NCDs. So our general objective was to create something which is bearable to the system. It has to be very low cost and sustainable. That is important because behavior change takes time, and it should take a lot of enthusiasm created within the system, otherwise it will be very boring, especially to the kids. So we were creating an exciting platform for the kids to being followed up. So we had few specific objectives as well. We were addressing their caregivers and to improve their knowledge as well. We wanted to have a monitoring platform to have our records secured. And we were not stopping there. We wanted them to feel important. We wanted to reach to their schools because most of the time they start some behavior principle and they stop it because of the peer issues. So we were just going out of the system and reaching to the schools also. So these were our methods. So baseline nutrition follow-up and assessment was conducted. Dietary counseling, those things are usual things. Special consent was taken because we are putting them into a hybrid platform. So these are the things that we do. We were just posting, we were creating, we just created a nutrition support group, which is WhatsApp based, and we were posting weekly health messages in the base mode of questions. So kids were compelled to answer these questions weekly basis. It's like simple dosaging every weekly about some kind of health message. And also we were having monthly virtual Zoom groups to discuss their personal issues and quarterly workshops with some games and nutrition related information, lifestyle and nutrition to be given in an interesting way. So also we were just making the caregivers aware of how to make a diet arrangements, menu planning, and how to create a healthy nutritional and lifestyle environment at their home settings. So we just reach to schools through their kids so they can come up and arrange a school meeting for us. So we went there and we were talking to their whole school on behalf of our kid, which made that kid proud, and they were just feeling good about it. And the message is spread over to many kids. So this is our quarterly in-person workshop. So it is full of games, and we were just giving them some gifts, and we were transmitting the knowledge through interesting activity-based manner to the kids. So yearly based, we were planning some event. So this time it was an art and craft competition, and we have many more things to come in the pipe. So our output was very interesting because we had a follow-up patients more and more. We saw them, some were seen for the third clinic visits as well. So WhatsApp messages were answered by 52% of average. They were really into it with the knowledge. And physical activity engagement of kids were increased up to 200%, and their active days were increased to the system. Impact at a glance was very impressive, but it is not the final result. Fruits and vegetable intake was significantly improved because they were always weekly given the simple dosage of nutrition and lifestyle care. So reduction of packaged snacks, which is a great harm, the ultra-processed biscuits and sugar-sweetened beverages. So we were just checking kids with that, and we are very happy that we could behaviorally and habitual usage was stopped in 46% of kids. And number of families who were habitually going to the outside food and very non-realistic food habits were stopped in a significant number of patients. Capacity building in the school setting. So there were 2,000 students in that school and 100 teachers. So the caregiver satisfaction was amazing. Everyone thought it was great, while 94% thought it was really, really useful. They don't have to come, but still they are getting the knowledge and the sustainable involvement of the care. So the perceived behavioral impact, what they felt was very 100% again, and they were strongly and agreeing, and none of them were disagreeing. So from their perspective, how easy this is, how cumbersome this program for them was assessed, and they none of them were said this is really cumbersome. They were very happy with that, while 11% were neutral with it, and most of the majority were very happy with what we did. And overall program satisfaction was 100%, and strong agreement was 40%, 41%. So this is very sustainable because it is hybrid. So this is, we started this in May, and it is cost neutral. We were creating a digital platform and digital tracking platform to follow up, and the groundwork and the continuity was very safe. And this intervention improves the leadership qualities and good behavioral change in kids, and activity retention, and staff and everyone was very happy because they are also getting very confident about their skills in patient care management. We want to make it a wider program where the kids are being as health messengers to their schools, and they feel very good about it. So we are thinking about health ambassador posts and very giving them some feeling of importance. And we have to think about this peer-led nutrition champion initiative in future, what we are working on it. And this system is amazing because it is hybrid. No one is wasting their time on it. It's a group, shared medical care, and sustainable care. Thank you.
Thank you, Dr. Malwatha. Again, she's a consultant, clinical nutrition physician. We have to thank Secretary Dr. Sandanayaka, 2 consultants, 2 projects from NI, National Institute of Infectious Diseases. Thank you so much. Over to you.
Thank you. Very creative, out of the box thinking, and it's good in terms of target grouping. Thank you. I'm just also thinking that there's a lot of potential for long-term follow-up and evaluation in terms of, I guess the weight status, particularly to find some, So what plans do you have in that regard?
Yeah, we have done the complete anthropometric profile. We are yet to see any differences because we are only 5 months behind. We are just following up the metabolic profiles, fasting blood sugar, lipid profiles, fatty liver, and while to the weight-based and height-based, because they are growing in height, so we can't just focus about weight because they are anyway gaining weight. So we are very scientifically following them up while making them very strong with their food habits. And we want them to follow the correct food and send the message through them to the families and to the community.
Yes, I went back to my health education era. Now it is called Health Promotion Bureau. And I see the hospital, health promotion hospital in your National Infectious
That
Hospital.
is happening separately. We are just trying to make it a health promotion hospitals. We are focusing on staff health and
no, even this one per se is a kind of a health promotion hospital. My only worry is now you are a specialized hospital. there are several specialized hospitals like that. But can it be replicated in other hospitals? That is my question.
Yes, it is very easy because it costs nothing. It only what I had to do was improve their enthusiasm and work capacity on my available staff, clinic nurses, and already available medical officer. And so it is anyway we were doing this, but we were not getting any results because of the lack of follow-up. So we are just putting the things into a follow-up system. It is not really an extra work. It is just securing what we do to see a future result. So actually, to be honest, I was placed to a different hospital. I'm now working in Valisara Hospital. I had to go with the replacement list, but still I could give my expertise through the Zoom-based things, and I'm involved in the teamwork here, creating messages, and so this can be done distantly. So this can be applied at any hospital. I think everyone should, because if we work, it has to have a end result. We have to reduce the number of people dying because of this. You can't just go and advise adults and do this. This is the young community. You have to grab them, hold their hands, and take them through with a lot of kindness. Thank you.
Yes, thank you for your presentation. Obviously, it's something that has to be taken forward, not just within your institution, but to other institutions. I'm wondering whether this type of application can be moved into our public health systems, into lifestyle clinics.
Yeah, actually, I'm very happy to contribute. I'm a lifestyle physician as well. I advise on sleep, physical activity, and all these lifestyle pillars. I'm happy to work at any platform with regard to this setting. Thank you very much.
Any comments from the audience? If no comments also, then we can.
Thank you very much.
Okay, let me invite Siraj M for the number 7 innovation, implementation of innovative polytera flow. Oh, okay, I think I'm going to misspell it. Okay. Project, yeah, PTFE, material refurbished oxygen inlet pipes in oxygen regulator units, a cost-effective and durable alternative to conventional apparatus.
Well, actually, as administrators, we have to appreciate and congratulate our physicians and the consultants actually for their innovative and active playing innovative and active role in their institutions. Thank you.
Co-chairs and my respected panels, mentors, teachers, and my dear colleagues. Very good afternoon, you all. I'm Dr. Siraj Muhammad Ibrahim, Medical Superintendent, Base Hospital, Walasmini. Today, I'm going to introduce regarding our innovative idea on implementation of innovative polytetrafluoroethylene material refurbished oxygen inlet pipes in oxygen regulator units, a cost-effective and durable alternative to conventional apparatus. Oxygen regulators are an integral component of oxygen therapy. Oxygen must be meticulously regulated to obtain a sound clinical outcome. The integrity of oxygen regulatory mechanism is of utmost clinical and biomedical importance. Some of the inlet pipes of oxygen regulators currently, they are corroded and damaged, mostly at the top of the area. As a result, they must be removed from service and new oxygen regulators need to be procured because this is not available as a separate part. This is the oxygen regulator as a whole. We are talking about this part. Our objective was to address the frequent damage and replacement of oxygen regulators and to find a solution to the common malfunctioning point. The damage leads to the entire unit irrecoverable and necessitates the replacement. This unit to be replaced by the whole component. Our aim to mitigate substantial financial stress and to mitigate the absolute hindrance to optimum uninterrupted provision of oxygen therapy. The gas pipe of regulators cannot be purchased solely. Without the gas pipe, regulators cannot be used. Approximately, it costs about 25,000 on a new regulator. To overcome this, the issue came up on our therapeutic committee meeting, what we are having regularly on monthly basis. And the team from the ICU produced this suggestion. We can use the PTFE, material refurbished oxygen inlet pipes in oxygen-related units. What is this? It's a synthetic fluoropolymer of tetrafluoroethylene. It's commonly known as Teflon in Sri Lanka, and there are so many other trademarks in other countries. It has waxy surface with a very low coefficient of friction and has high chemical resistance to most substances and high thermal stability. Non-flammable, about melting point is 327 degrees Celsius, and excellent electrical insulation properties. Resistivity is 10 to the power 18. And it's used in many ways in our cookware, industrial, electrical, textile, even our medical sector also. It's used as prosthetic material in surgical implants. And also in other bearing, bushings, and lubricant. As a result, one of our ICU nursing officer who had the experience came with the solution. This is the damaged pipe. And the Teflon is available like a rod. It's mostly available in our lathe machines factory, where a small part of this removed and the part is replaced by the Teflon. It's so strong. Simply, it comes on like 3 inches thick. First, they made the outer core, made it to the small one. Then the inner core is made. Then this part is made to fit into this, and more damaged part is cut. And in the top part, the thread is made. And finally, can be used an issue. And this is the previous one, and the alternative one is here. The real cost is only 600 rupees. We noticed this only last for about 6 months, around 6 months. We got 3 damage. We repaired, they are in use. This one for sample, which will be done by next week. Here, when we are fixing, we didn't use any adhesives or anything. Just the diameter is fixed into this based on the calibration of the lathe. Just fixing it, nothing else. The thing is, it's freely available, can be purchased easily and inexpensive. And it's stronger, not prone to frequent breakage, and it's easy to make. It takes for about 10 to 15 minutes. Therefore, it no need to be replaced often. It's made of durable material, and it minimizes risk also, such as breakage during treatment. Therefore, there is no delay in supply of oxygen, and refurbishment cost is very low and can be used our petty cash. In conclusion, implementation of this material refurbished gas inlet pipe successfully addressed the frequent damage and replacement of oxygen regulator. The innovation offers a durable and cost-effective alternative to replace the entire unit. Therefore, it can be adapted for managing damaged gas pipes of oxygen regulators to reduce financial burden and enhance continuous optimal supply of medical oxygen. Thank you.
Thank you very much. You have saved us some time also. Over to you, the judges, for your
Well done. I think you missed the second calling as in a career of engineering, which you should consider. And I think it also has good potential for commercialization. You should be selling this to the oxygen regulator manufacturers.
I had wanted them to take the patents is for this.
It's
Yeah.
quite right. I think that's a very necessary thing. You need to pay it. Marketing it to the regulators, I'm not sure that they're going to be very happy with this. They would rather make more money by telling you the entire regulator. But an excellent innovation.
And one more thing, to prevent this further, now we have started marking on the regulators also. Earlier it was not there. Then whoever make the changes or wash, then he knows, okay, this is the correct position to stop. Otherwise, the overturning may cause the damages. Even inside also, we are making, outside also, there is a mark. Then all the staff who are using this have an idea where to stop and no further turning of this.
Questions from the audience? Okay, please.
Thank you, Dr. Siraj. It's a very high product innovative process and very economic. And I am wondering, because we have coated with Teflon, so whether it is respiratory friendly, because it is working in the bubble environment. So there is more chances the molecules come out and going into the respiratory side. So what do you think about this?
Yeah, it's there's no reaction with any chemicals, one thing, and the melting point is 327, so high. Regulated. It's not coated, it's outside only tube. Only this part is covered. Oxygen coming through this filter, then through the water, it goes up. You're asking about the evaporation and thing, no?
Yeah, anything, because it is working in a dynamic environment. That is why I'm worrying about it. There is a possibility of dislodging of this Teflon. It is totally made from the Teflon or what?
Total Teflon.
I mean, clarify more. What was the material used earlier for the regulator? Is it the same or is it another compound?
Compound. Okay, this is the plastic what is commonly in use. Here we have replaced this top part with the Teflon. That's all. But to give you further answer, I have no idea. I think it's better to discuss with the chemical engineers, then only they can give the better idea.
Better consider that.
Yeah.
Okay, any more questions or we can?
Thank you. Thank you for the question.
Yeah. Right. Last but not the least, Myron N will be presenting the innovation number 9, providing beds for all inward patients admitted in medical units in teaching hospital Batticlo. Okay, I underline all patients in medical units. Okay.
Meanwhile, actually, the representative is ready until such time. Yeah. Go ahead, Dr. Myron. So Myron, why actually did you not given actually the presentations earlier? No. Meanwhile, actually, that I will actually give, I would like to actually give some informations regarding 2 years back, actually, we announced all the director, sorry. 10 minutes. Two years back, actually, we insisted actually all the directors to introduce mechanisms to improve the efficiency of doing medicals, confirmation medicals for the government servants. Okay, so then, yeah, so then we'll.
Good afternoon, distinguished chairs, respected colleagues, and in fact, invited guests, ladies and gentlemen. Today I will be presenting our quality improvement initiative titled Providing Beds for All, Inward Patients Admitted in Medical Units in Teaching Hospital, Betty. Let me start with the introduction. Teaching Hospital Betiklo is the only teaching hospital in the Eastern Province serving population of more than 2 million people across the 6 districts. The hospital has total bed strength more than 1,200 beds, providing care across the major specialties and subspecialties. When we look at the overall hospital performance, the average bed occupancy rate is around 70%. This means out of 1,257 beds, approximately 377 beds are free on any given day. However, this spare capacity is not distributed where it is needed. Some wards, particularly medical and surgical wards, experience bed occupancy rate exceeding 100%, especially during the casualty and post-casualty days. This means that these units are functioning beyond their physical capacity, leading to patients without bed, corridor care, compromised patient safety and dignity. A bed is the first step towards the recovery. This photo was taken in Teaching Hospital, Betiklo. Patients are lying on floor. Providing a bed is not just physical space. It protects dignity, ensures safety, support privacy and confidentiality, enhance infection control, and vastly improve the patient experience. It also reduces staff workload, promote psychological well-being, and contribute to natural healing of the patients. I repeat again, the bed is the first step towards the recovery. However, due to inequitable distribution of admissions, some units experience severe overcrowding while others remain underutilized. This mismatch results in patients remaining without beds, affecting quality, safety, and patient satisfaction. Objective of this study is to ensure that every inward patient admitted to medical unit of Teaching Hospital Betiklo is allocated a hospital bed through revised admission policy for medical wards. Let me now take you through the methodology of this study. This project was carried out in medical wards of Teaching Hospital Betiklo. There are 4 medical units, including the professorial unit. Total number of beds is 242. Let me explain the methodology of this study. We adapted a mixed method approach to ensure the both quantitative and qualitative approaches. First, we have analyzed the secondary data, especially the bed occupancy rates obtained from the hospital online statistics portal. We have collected the data pre-intervention and the post-intervention. Pre-interventional data collected in April 2025 and the post-interventional data collected in July 2025. Second, we conducted the series of key informed interview included discussion with hospital director, consultant physician, and consultant emergency physician. Finally, we carried out focus group discussion with in-charge nursing officers of medical wards. The results, before the intervention, we observed a significant imbalance in bed utilization across different medical wards. To begin with, all the casualty wards had bed occupancy rate of more than 100%. This means these wards are functioning beyond their physical capacity. Similarly, the post-casualty wards also demonstrated very high occupancy with a bed occupancy rate value consistently above 100%. In contrast, the non-admission medical wards were underutilized with a bed occupancy rate less than 70%. This clearly highlights a misalignment between the patient flow and the bed allocation. Let me introduce the intervention. Under the revised admission policy, patient allocation was recognized based on clinical triage category and the time of the admission to ensure the more systemic and equitable distribution. The time schedule, time slot A, 8 a.m. to 12 p.m., slot B, 12 p.m. to 4 p.m., slot C, 4 p.m. to 8 a.m. The triage category, there are 1 to 4 triage category. The category 1, it's a critically ill patient, and the category 4, patient with chronic or less urgent condition requiring the hospital observation. This is the comprehensive revised admission policy for the medical wards. During the daytime, from the 8 a.m. to 4 p.m., only category 1 and category 2 patients were admitted to the casualty wards, which was shown in yellow box. Meanwhile, the category 3 and 4 patients who are clinically stable were admitted to other 2 sub-casualty wards operating in 2 separate time slots, referring time slot A and time slot B, which was shown in the green color. After 4 p.m., all the admission, regardless of category, were directed exclusively to the casualty wards, which were shown in the blue color. Let me compare the pre and post intervention phases before implementing the revised admission policy. The casualty ward was consistently operating at the bed occupancy rate of more than 100%. However, following the intervention, we observed a significant improvement. During the post-interventional period, the bed occupancy rate dropped to below 100%. This indicates that the first time the workload became manageable within the available bed capacity. Similar patterns were observed in the post-casualty wards. During the pre-interventional period, the mean bed occupancy rate in all the post-casualty wards was almost always above 100%. After introducing the revised admission policy, the situation changed significantly. In the post-interventional period, all the post-casualty wards demonstrated mean bed occupancy rate below 70%, reflecting a more balanced and sustainable patient group. In this table, we compare the non-admission wards during the pre-intervention and subspecialty wards during the post-interventional phase. These wards consistently shows mean bed occupancy rates below 70%. Let me conclude with the results of the overall bed occupancy rate in all wards. During the pre and post intervention, bed occupancy rate of casualty and post-casualty wards were improved well, which were statistically significant, whereas bed occupancy rate in non-admission wards left uneven. Overall data demonstrate that the revised admission policy greatly enhanced bed utilization in high pressure areas, namely casualty and post-casualty wards. Conclusion. The introduction of revised admission policy for medical units significantly improved the equitable distribution of beds for patients. It reduced overcrowding in high demand wards in optimized available resources. It's recommended that this policy be continued and periodically reviewed with potential for the replication in other clinical specialties facing similar challenges.
Thank you, Dr. Myron. It's again actually the highly timely important project because all the hospitals are the medical units are the mostly occupied units. Okay, so then there are so many low patients even. So then I think good project. So it's over to the panel of judges.
Yeah, thank you. That was a good presentation because it's I think for some hospitals which obviously have a very large area that they cover, a large population, you're draining a very large catchment area. And I'm sure this has to be done also possibly in other places where they have similar situation. I think my big thing where the biggest challenge that happens, I think, in these type of institutions is how does staff compliance to this type of thing? Because the attitude of the staff has to be changed. You're distributing a problem among them. How do you change that?
Yeah, so actually this was the same problem to change the attitude of the nursing officers and medical officers and the consultants. So the big problem was with the consultants only. I have presented with the statistics, they have agreed. But still, we didn't do any changes in the weekend policies. Still, even we have 4 units, but still we have the weekend policies. That means Saturday and Sunday, the 1 unit is being the admissions. That means Saturday, Sunday, definitely the bed occupancy rate is high because the 2 admission following the Saturday and Sunday. We couldn't change that one. Following later only we have to do that. But initially the nursing officers were not happy with that. But after the intervention, they have given a good feedback that they said, now the workload is distributed similar. So they are working very happy, they said, from the nursing side.
Thank you. Just interested to know, did you see any, I guess, impact on staff nursing rostering or, the skill mix between wards that you had to change as a result?
I didn't get you. Sorry.
So the number of nurses per ward and the different skill sets that they have, skill mix per ward, did you observe any changes that had to be made because the patient numbers were changed?
Yeah, this is only in the medical ward we have implemented. So there is no need of skill mix, but actually once the patient goes to the new admissions, the matron will distribute some other extra nurses to that ward. That's how they manage the roster.
Any comments from the audience?
Turnover rate, I didn't calculate actually. We should take some time.
Must analyze other things, root cause analyze. What is the root cause analyze?
Root cause, what are the causes you? The root cause. Because of more admission in the tertiary care hospital, that's what the
Are
reason
you-
of bed occupancy
Yeah.
rate going high. So that is tertiary care hospital. Otherwise, we have to strengthen the base hospitals all over the particular districts. Then we can reduce the admissions. So that is policy should be made for the step down hospitals.
Yeah, thank you very much. We are having the last online. I hope everything is ready for that. Fernando GHS will be presenting number one, actually it's on the list, an innovative initiative to improve blood pressure and blood sugar control at medical clinics of Matale District Matale District General Hospital through patient-friendly monitoring chart.
Uh, Good evening to all of you. Can you hear me? Can you hear me? Can you hear me, please? I know that. Right. Can you hear me? Can you hear me, madam? Hello.
Yeah, we can hear you. Go ahead.
Good evening. Thank you for selecting my project for in this program. I am Dr. Susantha Fernando, Director DGH of Matale. This is my project is an innovative initiative to improve blood pressure and blood sugar control patient through patient-friendly monitoring chart. We know around 80 to 90% of death in Sri Lanka mainly due to NCDs. Majority of reason for due to uncontrolled hypertension and diabetes. These are the leading cause. The medical clinic in our hospital, we conduct some audit. It showed the patient who take in regular treatment, but blood pressure and blood sugar control is very low, just below the 50%. This consists and monitoring essential for effective management. We know a significant gap exists. Both clinician and patient struggle to quickly assess control status because the current method involve readiness, review of past clinic note, which is inefficient because in our clinic around 400 patients coming per clinic, only 3 to 4 doctors reviewing these books. It's difficult to see the past history of their blood pressure control. This leads to delay clinical decision and poor patient awareness, and there is a clear need for a simple, effective tool to bridge this communication gap. Therefore, our objective is to improve the control rate of blood pressure and blood sugar among patients attended to medical clinic by introducing patient-friendly, visually engaging monitoring chart. Therefore, we did fishbone analysis to identify the main reason for this is poor control, then did need assessment of an innovative project, and we designed an innovative project, and we did SWOT analysis to assess our strength, weakness, opportunities, and threats to implement this project. When we implemented, then review our success. Through the fishbone analysis, we found the main reason of poor control, medication non-adherence, unhealthy diet, sedentary lifestyle and lack of physical activity, insufficient health literacy and understanding, psychological factors such as stress, depression, anxiety, and inadequate self-monitoring, and clinical inertia is part of a clinical provider, then socio-economic barriers, comorbidities, and concurrent medication, and poor communication and lack of a strong patient-provider relationship. After that, we prioritize main reason according to middle group technique. We found four main top priority: insufficient health literacy and understanding, inadequate safe monitoring, clinical interest. Yeah, it is main part of a health provider. Then poor communication and lack of strong patient provider relation. We thought if we can give some solution to these four main category, most of the other reason automatically we can eliminate it. Then after that we need assessment of this innovative project. Then we interview 10 doctors who are in our clinic regarding their ability to assess individual patient blood pressure and blood sugar control who are coming to our clinic. All reported difficulty in identify control level quickly, often needing to refer back to previous clinic note because of this patient load. Then we interview 50 patients were randomly selected for the interview. Only 7, that is 40%, were aware of whether their blood pressure and sugar were under control, highlighting a widespread lack of patient awareness. They are coming regularly to our clinic, they are taking their drugs, but they don't know whether their blood pressure is controlled or blood sugar controlled or not. Therefore, based on the finding and supported by evidence from a literature review, two separate monitoring charts, one for blood pressure, one for blood sugar, were designed by our quality unit. These charts were validated with comparison with international monitoring chart and the expert opinion by our consultant who in our hospital. Then approval was granted before implementation from the management committee after evaluation at our quality steering committee. This is the two chart. You can see this is the blood pressure chart. This you can see this blue line. If it is you can one for year one form valid adequate for 1 year, it is 12 months. Every month they can mark their blood pressure level here. If it is in the blue, it is control, under control, because stages here. If it is over marked over the red line, we can see the control. The patient clearly can identify. This is a blood sugar chart designed by ourselves. You can see this green, this is a healthy level. If it is above that or lower, it is not under control. The key features of this chart: color coded design. Visually, we can clearly see easy interpretation, both clinician as well as the even lay patient, and easy to the local workflow integration and language accessibility. You can see clearly we identify the blood pressure even uneducated people. The first 250 copies were donated by one of our donor. You can see this is the blood pressure chart mark at the clinic. You can clearly see we mark on blue systolic blood pressure, regular, monthly. The red color the systolic blood pressure. You can this chart will be attached to first page of the book. Then any can snapshot, they can clearly see their blood pressure control, even patient. This is a blood sugar chart. You can see in the clinic how we mark in the blood pressure, blood sugar level in this chart. This chart were introduced as a result implement project. The chart were introduced in mid-May 2025. Healthcare staff receive orientation on effective usage, including how to enter data during consultation, track trend over time, and quickly identify out of range value. Result follow-up evaluation was conducted in the first week of July 25, involving the same 10 doctors and a new cohort of 50 patients. You can see all doctors new chart, they told new charts allow for rapid visual identification of the blood pressure and blood sugar chart, then significantly enhance the clinical decision making during consultation. This is comment from the doctors. The majority of patients could now, the patient awareness, all were aware, the majority of patients could now accurately explain whether their blood pressure, blood sugar were within the recommended range or not, indicating improved health literacy and engagement. You can see the data was we have to quantitative analysis. We done data were collected 140 random patient attending to our medical clinic during the month of June and September. This is a WHO classification for the hypertension. According to that, this patient on June the systolic pressure average is 146. Then September Within this few months also we can show a result, reduction 130, diastolic blood pressure also significant reduction. When the patient count, you can see optimum level. On June 25, 4 patients, it has increased to 40 patients. The stage 1, it was 22, it has reduced to 35. We can significant reduction, even small within this few months. Optimal B group increased by 67 and stage 1 hypertension decreased significantly. The total of 46 patients were randomly selected from the medical clinic. Fasting blood sugar value were recorded in June baseline and again after implement of new chart in September. You can see June fasting blood sugar 151, it is to 146. You can see the range also reduced. In patient wise, the patient wise 22 patient they show a reduction. This is significant even though small duration. Then we wanted to maintain the sustainability of program. In order to that, routine chart was supplied by from our quality management unit regularly, and staff orientation was conducted regularly from our unit. Then ongoing, we are regularly doing ongoing audit to see the control of blood sugar and blood pressure level from the quality management unit. We are doing regular patient education to make the awareness of this chart. In conclusion, a significant knowledge and communication gap exists prior to the intervention. The patient-friendly chart have successfully bridged this gap for both clinician and the patient. The tool has enhanced the efficiency of clinical workflow. It has improved patient self-awareness and engagement in their care. This simple, low-cost initiative is an effective strategy for improving chronic disease management. Recommendation: expand the use of this proven chart to all relevant clinic, and we are conducting ongoing clinic and long impact monitoring. And these are some references we referred when we design in our this innovative chart, and we locally we develop by getting example from the other implemented chart in the country. Thank you very much.
Thank you, Dr. Susanta. We have completed on time. So it's up to the judges. Any comments?
Thank you for the presentation. I just wanted to ask you about the interviews of when you think you were talking that you interviewed 10 doctors as well as the 50 patients.
Yes.
The nurses, you have forgotten about the nurses, or why you have deliberately not included them? I mean, I think the doctors, nurses are also part of the hospital staff.
Mainly the management wise decision taken by the doctors. Therefore, it is important for doctors and as well as the patient there who get awareness about in the nursing officer in the midway. However, we have trained, discussed, due training programs, or even not nurses. Yes, next time we are getting their input as well.
Just very quickly, did you also map what advice and strategy was given to patients if they're identified in a certain box, or what strategies were put in place in terms of healthy behaviors, medication prescribing, etc.? Because how do you know that introduction of charts is what led to the reduction in blood pressure and not certain interventions?
Yes, this is the patients are regularly coming to our clinic and taking treatment regularly, but the patient awareness is mainly awareness, and doctors awareness very essential to take decision. The patient, we have separate health education unit in our hospital, and they are regularly attend to the clinic. According to this chart, because we are doing auditing, then audit result will be given to our health education team. Then they will make aware about this other, because before giving advice we should know whether control or not. this implementation, we can clearly identify whether they are controlled or not. If it is not under control, now we are regularly educating based on this result to the patient by our health education team. Exactly, we are giving other educational program to improve the blood pressure, because other than the other defects, we are completing that.
Yes, we all realize, I think, in our country that while we are performing well in screening for blood pressures and blood sugars, the control is the issue. Despite them coming to our clinics and despite us, the compliance with medication, it tends to be a problem, and thereby, therefore, poor control. So have you seen that this chart is linked to directly to good compliance in drugs as well, taking of drugs?
Exactly. Exactly. If we be simple chart, the civil patient and the relative also can clearly identify their pressure, blood sugar control or not. The problem is, even though they are tracking, they don't know whether they are controlled or not. You can see the similar our child health development chart. In the chart, if they say a deviation, they are more, because of that they are trying to get advice everything from the sales staff, but knowing there whether their control is not under control, they are trying to adhere to our recommendation, and drug compliance will be increasing. We saw that as a result of, because when we are interviewing the patient as well as doctors, we clearly identified the compliance has been increased because of, but by knowing their blood control is not under control. The issue was the patient doesn't know whether it is controlled or not. Even our doctors also, because of this heavy workload, they can't see their previous records. Why introducing this snapshot, even doctors can give advice because of this under poor control, because they are now know they can change the drug regime according to the result. Even patients know this is control or not. Visually they can see. Then they are trying to more adhere to our advice and drug compliance.
Thank you.
Okay, as the time has been concluded, let me give to my co-chair, because he wanted to tell something several times and he could not finish it.
Thank you, madam. So I want to actually first congratulate all those who have actually conducted the innovative thinkings rather than actually maintain the status quo. So then they have tried to flying out of the paradigm. So then that's the thing we are actually expecting from our young administrators. Okay, then second thing, actually, they have actually implemented many things. So, but anyway, that sometimes, so you can, as we requested at the beginning also, so you actually that share your experiences with others and try to implement in other institutions as well. And I have actually, with my experience, I have visited many hospitals. I have seen the yesterday also we discussed, other than the reducing the bed occupancy. So then another innovative strategy is to actually implement the step down hospitals. There was a hospital in northern province, Chankane Hospital. They have implemented in a very well manner with step down care for the what do you call the stroke patients.